endourology. The first session today is on endourology. I call upon my co-convener, Dr. Tanuj Paul Bhatia, on stage. I welcome Dr. Saeed bin Hamari, our invited faculty from Saudi Arabia, to take the dais. I take pleasure in inviting Dr. Chandramohan Vaddi to chair this session. The first session in endourology is nightmares in PCNL. I invite Dr. Dilip Kumar Mishra, the moderator for nightmares in PCNL. Over to you, Dr. Dilip. How to change the slides? Can I have that? Dr. Abhijit? Yeah, before we begin, I thank the Youth Council and Youth Conclave for giving me this opportunity. And before that, this is a session on complications in PCNL. I would like to invite the panelists, Dr. Sagarika and Dr. Satish, please to come on the dais. And I think the other two panelists are not there. You can upload my presentation, please. Okay, so endourology, mainly I'll be concentrating on just PCNL. Can play the slide, please. Okay. So PCNL is a really nice surgery. All of us are doing it for large stones, and all of us are not very experts in doing PCNL. So we'll end up in some complications and troubles. So this session is just about how to prevent these complications, or if you land up in one such complication, how to go about it. So I'll be discussing a few cases in this and taking the opinion of my panelists as well as the chairpersons as well in this. So before we start, if complications happen, just be patient. Like a kidney stone, this too shall pass. So this is the first case. The history is 50-year-old female, pain in the right flank, otherwise NAD. CT showed 2.2 centimeter right renal pelvic stone. Biochemistry is within normal limits, no comorbidity. This is the CT picture. So my first question is to Dr. Sagarika. What would be your approach for this case? And you're not allowed to say RIRS because this is for PCNL.
Yeah, I will go through the posterior inferior calyceal only.
Okay, good. So this is another, again, CT images. We can have axial images to see whether it's in how is the posterior calyx or how is the entry calyx. And then maybe we can accordingly plan our puncture. I agree with you with the last image we saw, and maybe we can plan it better after doing an RGP. So it's a straightforward case, just child play case. So what you did, Dr. Sagarika said to the resident, go and insert an ureteric catheter. And I believe you're planning to do a prone PCNL. So your resident went and put in a UCath like this, see? And turns the patient prone also without asking you, and then invites you. Are you concerned with this image? Would you like to change something, or would you happy?
No, this is a very common problem we can face as a resident.
Yeah.
So first of all, I would like to withdraw the ureteric catheter under fluoroscopic guidance.
Of course.
And then we will push the contrast and we can see whether we can delineate the required desired calyx or not.
So would you like to do that in the prone position or in the supine, while in the lithotomy position itself?
We can withdraw the ureteric catheter in prone position as well, and we should always be vigilant whether the time
Okay.
that we used to be in, that is, in most of the times we put it very tight, so we can loosen it, and so that we can have a easy manipulation under, of course, under fluoroscopic guidance.
Okay. What's your opinion, Dr. Satish?
Morning. See, what I usually do is I insert a ureteric catheter, but being now at a private practice, we don't have fluoroscopy access at all times. So, and if you want to follow ALARA principles, as low radiation as possible, try to minimize. So what I do is I insert a ureteric catheter,
Okay.
and I see whether the urine is effluxing or not. And two things I need to know: urine is clearly effluxing, I know that the system is communicated,
Okay.
and there is no pus inside. So that usually solves many of my problems, even if I don't have.
So you go with the markings on the ureteric catheter, just 25 centimeter, you push it in, and that's it.
No, I push it in without any resistance,
Okay.
and see that there is clear reflux of urine.
Okay, fine. So, but in this case, what happened? The patient was already prone, and the ureteric catheter was like this, as you saw on the fluoroscopy while you're planning to make a puncture. So you already told what you would do. So I was an overconfident surgeon. I said, okay, fine. This is just, curving a little bit. I'll just pull it out, and it should be fine. Things will settle. So what happened? This happened. So this, you see, it seems that it's a straightened ureteric catheter, but it's not. Actually, the catheter is bent acutely over itself. And then I tried to push in contrast. Nothing is going in. Patient is in prone position, female patient. And I tried to push in a guide wire to straighten it out. Again, nothing is going in. So now what to do? What should I do? Or what would you do?
So try to pull it out. Since a female patient, we can always try to pull it out as long as it becomes straight and reinsert.
I tried, but it was not straightening. It was coming out in the bent position itself.
Position. Okay.
So how to plan the puncture now?
If you are an institute, use the ultrasound guided puncture.
You don't have an ultrasound.
Then I puncture stone guided, instill contrast directly, and then plan a calicel puncture.
Okay, madam, what would you do?
If ultrasound is there, then it will be, our job will be a bit easy. Otherwise, we will do the stone guided puncture.
No, so now see, the thing is, you all are very experienced. You can do a stone guided puncture or anything. I would like to ask Chandramohan sir, like what a beginner should do in this situation. The ureteric catheter is acutely bent, no contrast is going in, and you don't have patient is prone position.
I understand.
Yes, sir.
I feel resistant to puncture stone guided. That's the last option.
Last option, yes.
So I try to remove that and settle that matter before you proceed. I want to take out that ureteric catheter and reinsert slowly. Probably it might have kinked. Take it out. What is the harm?
Okay.
If it is not coming out, you have to face after 1 hour the same problem.
Okay.
So better face no stone guided puncture because slightly medial, going unnecessarily inviting problems.
Okay, I agree with you, sir. For a beginner, doing a direct stone guided puncture might lead into problems. What should be done is, yes, obviously, if you have an ultrasound, best is to do an ultrasound guided puncture. But if your ultrasound is not available, you can do a stone guided puncture. That's what I did. Just puncture the pelvical system to fill the system. To fill the system, find out which is the appropriate calyx to puncture, and then take a definite puncture later on. That's what I did. So I could make a puncture. There was some contrast extravasation outside, and I could pass in a guide wire which coiled in the upper calyx and went down to the ureter. I was able to clear the stone. Now, this question arises. Still, the bent ureter catheter is still in the upper ureter, gone beyond. What will you do? Will you pull it out, or what should be done? Madam, you can answer, please. You have cleared the stone, and you just have the bent ureter catheter, which is lying in the upper ureter, little away from your puncture.
We will push the guide wire down to the catheter, down to
Yes.
the ureter, up to the bladder, and then we
Yes.
can take it out the ureteric catheter, and we can do the stenting.
Yes, you can do the standing, but pulling that ureter catheter, which is bent
Yes,
on
that
itself,
is-
will it be advisable? Dr. Satish, what's your point of view?
Since now we have antegrade access,
Yes.
if I have see the bend and I remove it open, so that the ureteric mucosa will not be traumatized.
Yes, that's what I was, that's the point I was trying to raise. So if you pull it out, because it is bent on itself, it might injure the mucosa, and it might, pull it out also, and it might cause a lot of trouble. So better is to pull it out from the Amplas sheets. You have an entry gate access already, pull it out, and then that sorts out your problem. So this was the first case.
No, this
Somehow
is,
I managed.
sorry to intervene.
Yes, sir.
And ensure that the ureteric catheter is cut into two and thrown out.
No, only a little part of it was bent.
Because we should not mistakenly use the same ureteric catheter again after
Yeah,
sterilizing.
that is correct. That is right. That's the right point. Okay, so coming on to the next case. So this is again a 23-year-old male with the right flank pain, no fever, vomiting. CT shows 1 centimeter stone in the lower calyx and pelvis. Biochemistry is within normal limit. You can see the CT images. Again, now Dr. Satish, what would you do? Again, no RIRS. This is PCNL session.
PCNL. So young male 1 centimeter, I'll plan for a PCNL, preferably mini PCNL if I have
Yes,
access
it's
to
a
it.
small stone, you can go ahead with a mini PCL. I agree with you. So this was again a simple case. So ureteric catheter in place, no problem, no problem. RGP showing a nice dilated lower calyx, and the stone is almost lying in the lower calyx. And he made a puncture, bullseye puncture, and what happened? As soon as you remove the stellate, blood is coming in out. Try to adjust the needle. Again, blood is coming out. Try to aspirate. Blood is coming. What to do?
No, if blood keeps on coming, it is better not to dilate the tract.
Better not to dilate. So what would you do? Like needle is, what might be the reasons I have already mentioned here. It might be, maybe you can just say needle might be just outside the calyx. It might be an infundibular puncture which can bleed like this. Needle might have been inserted directly into a blood vessel which might be bleeding. So if the blood is coming, I would generally not dilate that tract, and I would try to reassess the puncture or readjust the puncture. So what happens if you're making a puncture directly, the ideal puncture should be like this, which is going through the middle of the papilla into the calyx. And sometimes the puncture is like this, it is through the infundibulum. This is not a correct puncture. Anyways, so we readjusted, and so that was a good, we could readjust and make a nice puncture. It was an easy case. So guide wire went in and we could clear the stone. No problems. Okay, that's about the needle. So I'm sorry, I went ahead a bit. So once we put in a needle and guide wire, then there, as soon as we dilated and we found that blood is coming from the access sheet. What to do, Dr. Satish?
So it's probably under dilated first.
Okay.
So we need to readjust the amplats under vision and see that the guide, once the guide wire is in the system, we see the pelvic mucosa and readjust the amplats.
Okay.
And first check the blood pressure of the patient. Many
Okay.
times patient would have come out of anesthesia. BP may be in hundreds, 100s and something.
I
and-
completely agree with you. First, as you said, we'll confirm the guide wire. We might do a scopy and see if it is just outside the amplastic is just outside the system. We might just,
Push it in.
twist the amplastic and push it inside the system, and that might help. And if there is an under dilatation, once the sheath head, twist the bevel sheath over. Sometimes little part of the parenchyma is bleeding, and so you just twist the sheath and cover the parenchyma, and the bleeding stops. Sometimes there might be over dilatation also, which you might not realize. And then if there is a counter puncture, what would you do generally?
It depends upon how much I have dilated. So if I have dilated more and if the bleeding is huge,
Yeah.
I usually stop the procedure.
Yes.
Or usually what we do is we come out, go into the system. If the effluent is very clear and if the stone is small and easily breakable, we complete it.
I completely agree with you on this point. Madam, what about you if there's a counter puncture, if it's a big puncture, counter puncture, there's a big rent?
If the bleeding stops, if first of all, we'll observe for some time. If the bleeding stops and patient hemodynamically is stable, then we can proceed. Otherwise, I will, as far as I'm concerned, I will abort the PCN and come out.
Yes, I completely agree with this. Chandramohan sir, what is your point on this?
But Sarika,
Thank you, sir. Thank you so much. Dr. Saeed, what would you say? Amplats you have inserted, it's underdilated and it's bleeding.
Well, this is what I say. Always PCNL is the axis. If your axis is not correct from the beginning, you just stop. This is my advice for the beginner. But if you have some sort of bleeding, you can have a look because some sort of bleeding will stop immediately. But for the beginner, you stop.
Okay, thank you so much. So we'll proceed as Dr. Satish told, we just reinserted the amplas little bit, advanced it ahead, and we could clear. So procedure went well. There was bleed after remove the ampla. It was bleeding like this. What would you do now? Just have a look at the clip. Madam, any suggestions what to do now?
Our practice while we do PCN, after putting
No,
the.
we have finished the PCNL,
No,
we
sir,
removed the
that is
stone.
what what we do exactly. We always put a safety guide wire at the end of the procedure after putting resistant also.
Okay.
Even if so this happens, then we will have a access so
Yes.
that we can,
Very
you know.
right. This is not my case. So very right. Before when you're removing the amplas, you should have a guide wire in place. If something like this happens, you are able to put in a PCN or a large bore tube to stop this bleeding. So what else can we do in this situation?
Shall I be the
Dr. Satish?
devil's advocate now?
Pardon?
Shall I be the devil's advocate now?
Yeah.
If you put a nephrostomy catheter, you actually cause less tamponade. It causes more bleeding. Your parenchyma keeps opening. So
Okay.
usually whatever we see, this type of bleeding comes through the dilated tract is from the tract.
Yes.
So you take a deep sutures and give pressure, it stops. Immediately when I see this bleeding, I
Deep
check the.
suture, you mean deep suture into the kidney or
No,
stopping?
sorry, we cannot take through the kidney. We'll take through the intercostal
Because
muscles.
generally this bleeding is from the parenchyma only. So even if whatever deep suture you take, I don't think.
But
He's saying not for stopping the blood.
Yeah.
Will form a
Content.
Okay, yeah, I agree with you.
Access tamponade, because most of the renal injuries are managed like that.
conservative.
Okay.
And
Dr. Syed, what would you do in this?
Can-
Yes, Tanuj, please.
Suppose this patient goes to the court in future and there is a panel or there will be another urologist on the panel and he will say, why did not you not put a tube in that case? So we have to think like that also today. If there's something happening, we have to take every patient as a potential litigant, I feel so. What do you say, sir?
What I am asking is, why want to put a nephrostomy tube in this?
Because book says so.
For?
Book says. he
Book
says-
says so.
No, no, no,
definitely.
no, no. No book says like that. You have to, sorry, no book says like that. Maximum, if you have upper ureteric stone, if you have not cleared, you can put stent, keeping the patient in lithotomy position. If you put nephrostomy, will you clamp it?
Yes, sir.
Yes. Yes.
Then what is the purpose of nephrostomy in bleeding is highly controversial. A tract which is bleeding this potential, tamponade is the only thing which we have to do, and you should be prepared for next 6 hours. Be prepared for the hypotension also.
Yes.
That is more important in panel lawyer, not the nephrostomy tube insertion or not.
I agree with you, Chandramohan sir. Nephrostomy tube doesn't help in this thing. I mean, stopping the bleeding, unless you're putting a bigger size nephrostomy tube, which is means putting some pressure on the parenchyma around, and it's like a say 30. If you have made a 20 French tract and you put in a 26 French nephrostomy tube, that might sometimes help. But in studies, it has been found out that it doesn't really help. But just to be safe, people put it, clamp it, so that later on they can find out that if there is some bleeding, if it clears off, then there's sounds safe. But logically speaking, it has not been found out that it helps anyhow to stop the bleeding. Anyways, that you already told what to do. So acute hemorrhage, what all we can do? We can insert and put a nephrostomy tube just for book's sake, as Tanuj said. We can apply pressure to the incision. We can let the collecting system clot off and form a contained hematoma, as Dr. Satish mentioned. We can, in this type of situation, some people say that tubeless approach is not advised, but we will go both ways. It depends on the surgeon. We can go tubeless also. We can put in a tube also. Both ways can be done. And sometimes, most of us now have not used this case nephrostomy tamponade balloon, but this can also be used in this type of situations sometimes. And you can use hemostatic agents. If you are having a ureteric catheter inside, you can give IV hemostatic agents, which might sometimes help. Anyways. Yes, yes, I agree. This is very disastrous. I agree. Yes, yes, I agree with you, sir.
Only your buying time, because you have to arrange blood, you have to talk to the parents, you have to explain.
Yes, yes.
Just buy time, that's all.
I agree with you. I agree with you, sir. So just a little bit more discussion going back, it's like what are the factors which are associated with the hemorrhage in a patient who is going for PCNL? So madam, can you elucidate some factors which you would look into beforehand, before going for the surgery, that, okay, this patient might bleed more, any factors which you would consider?
It may be as you are asking about the patients and all the investigators, right? So as far as first of all, regarding the patient's habitus, bleeding is more likely in the obese patients.
Yes,
And
I agree
secondly,
with
we
you.
should we should ensure before going to the procedure whether he's taking any kind of anticoagulants or.
Yes, I agree with you, madam.
And thirdly, any post-operative means prior history of any cardiac intervention post PTCA in
Okay.
those factors.
So,
And,
so we should, as she has already told, we have all these factors listed here. We can have, if any anticoagulation is going on, undilated system, infected system, obese patients, diabetics and CKD patients, and prior open surgeries, these patients tend to bleed more. So we should be wary of these factors beforehand and go with a little bit of caution. Any other factors, Dr. Satish, if you could tell me, which might lead to more bleeding?
Only thing, uncontrolled hypertension along with this
Yes.
intraoperatively. And many times if a patient was already on, say a diabetic CKD, rarely we see coagulation abnormalities also.
Okay, yes.
So we'll have to think in those angles also.
CLD is something to be very careful of.
Yes, yes, I agree with you. You have not
No.
mentioned that point. Yeah.
I have had one angioembolization, that was a CLD patient.
I will again try to be the devil's advocate here.
Yes.
So we had, I worked at a liver transplant center. So we
Okay.
had a lot of confusion regarding this chronic liver disease patients. Chronic liver disease patients are usually prothrombotic. They are not bleeding diathesis.
Okay, okay.
So we'll have to consider that in mind. We'll have more complications post-operatively because of clotting, DVT and cardiac clotting, and not bleeding intraoperatively.
Okay.
I feel technical point, long infundibulum with fat
Yes, yes.
in the CT with thick parenchyma. Oh, we have to be careful,
Yes, sir,
underdilate
yes, sir.
than overdilate.
And obviously multiple, if we are making multiple punctures for a stagnant stone and it's a long time surgery, then also patients might bleed. So you have to anticipate that beforehand.
One point of caution is the lower pole calyceal stone, which is 1 centimeter, where we think it is simple, that causes a lot of problems for us.
Yes.
So all
I agree.
patients needs to be taken carefully. And if the lower pole calyx is parallel to the ureter, our tract always goes through the infundibulum, and we did embolization in at least 3 such patients.
Okay, good. Nice points raised. So there might be some technical errors also which might lead to acute hemorrhage. There might be infundibular injury, as Chandramohan sir has already told. If you are making an access into an entry calyx by mistake, then you have to torque and go into the pelvis. That also can be a cause for acute hemorrhage. And obviously, if you're doing aggressive torquing, you're changing the angle here and there too much, then it might lead to bleeding. So we have to take all these factors beforehand and see which patients might be bleeding more and might require some.
Dilip, I want to ask you a question, same thing.
Yes, sir.
Your opinion. If you go inside first time in PCNL, small stone, if it is bleeding, that vision is 50-50%. Do you have any clue once you enter into the system? See, first puncture was bloody, people say don't dilate it. What about after dilatation going in, bleeding?
Bleeding, sir.
Will you continue stone removal, especially 2 centimeter, it will take 15 minutes? Or will you just stop and give nephrostomy or anything?
We can, sir, sometimes we can, raise the pressure of the fluid which is going in and see if it clears up, and if you're able to, find a leeway, you can see the stone. If it is completely bleeding and you can't see anything, better to stop it. I would not advise to go ahead in that case, because
Sir,
we'll have to stop.
bleeding once you enter into the system and stone is seen, but bleeding.
Once you have a clear vision, that bleeding is not important. So if you increase the fluid and you see everything is fine, so that bleeding is, don't be scared at the beginning. You have to, yeah, give them some times. True.
Okay, so now we have this last 5 minutes left, so I would just skip this bleeding. We have a lot of bleeding. We don't want to be scared more of bleeding, so I'd go ahead and just quickly skip off to the next case. Okay, so this is the next case. This was a 45-year-old male. He had a bilateral flank pain, left more than right. Bilateral stones were there. The surgeon who had this case planned him for right supine PCNL left followed by right supine PCNL. He placed him in GMST position and he tried to make an inferior calyceal puncture by triangulation technique. So clear reflex of fluid was seen. Glide wire went straight down into the ureter, followed by stepwise sequential dilatation of the tract. There was some difficulty observed during tract dilatation. Somehow still he placed the implant sheath and started doing scopy. So this is the scopy video which I am showing you. It doesn't look like, maybe sometimes renal parenchyma might look like this or may not look like this. So scopy is going on and you see this. This fecal matter there. What would you do? Madam, what would you do? You are the unfortunate surgeon in this scenario.
During the puncture, if we see, I think.
Puncture, you will not be seeing this.
No, not puncture,
you
means when
dilated
dilating the,
yeah.
when dilating
You
the.
entered inside and now you see this. Now what are you going to do?
So first of all, we cannot plan PCNL at this stage. And secondly, we have two separate drainage of the two separate systems, means calyceal system, as well as this, we have to put drain in the colon and then separate nephrostomy.
Now the initial slide I showed that the guide wire has gone directly into the pelvical system and down the ureter, means it was a nice entry. So what to do? Like you'll proceed with the same guide wire or you'll put what?
No, I will put a different puncture for the system because I have not experienced one in this.
Okay, Dr. Satish, you can elaborate, please.
We unfortunately had one such incidents
Okay.
where the theater was smelling with fecal matter. So that was intraperitoneal injury. So patient had 1.5 liters of fluid in the peritoneum. So we had no other go to explore.
Okay.
If there is a contained perforation, if there is no leak in the intraperitoneum, then I put in a standard nephrostomy tube and make it as a control fistula.
Okay.
And if the guide wire is in the system, I put another nephrostomy if possible.
Okay, great. Sir, would you agree with this?
First document with nephrostogram.
Let's be quick, sir, because we don't
a
have
little
time.
bit of contrast to inject, and then whatever Satish said is
Okay,
correct.
good.
Slightly for first 5 years consultant, better not to proceed with stone.
Okay.
Stop it there.
Abandon the procedure, not to proceed. How to manage bowel complication? What the surgeon did, he put in a guide wire into the colon, as he shows in this video, and then he put in a stent. He had an access because that was supine puncture he has planned. So he put in a stent into the pelvical system and put in guide wire inside the colon and put in a nephrostomy tube. This was the CT which he did. He was a very interesting friend of mine. He said, I did a CT after putting guide wire and putting in PCN to see what is happening exactly. And he got this. He had put in a stent and the guide wire, as you can see, it is traversing into the colon directly. So this is the PCN which he put in a Foley's catheter, and then he managed that both systems, compartmentalized the both systems and managed that as a fistula. And he had some troubles post-op also. He developed respiratory distress, tachycardia, abdomen remained more or less soft. He had pneumonitis. This was the CT initial image, which showed EJ stent and guide wire in place. So whether he had some troubles, whether he wanted to open or not, I'll just take 1 more minute, Abhishek. So he decided not to open, went ahead with good antibiotic coverage, NQ till 5th post-op day, everything settled, and he kept the colostomy bag on the side, discharged on 10th post-operative day. This was the fistula tract after that. So this is the crux. We have to see the distended colon, previous abdominal surgery, hypermobile kidneys, retrorenal colon, all these things we have to see beforehand in the CT scan, if possible. Avoid colonic gastric oil puncture and use a ultrasound if possible in this type of cases, and management, as we've already told, is done. So that's all. So this is to summarize the session. Thank you very much. Thank you, Dr. Satish and Madam.
Thank you, Dr. Satish. Thank you, Dr. Sagarika. Thank you, Dr. Dilip, for moderating the session. We would like to invite the moderator for the next session, Dr. Rahul Gupta from Jammu, please. And maybe invite the panelists, Dr. Manas Babu, Dr. Santosh, Dr. Vamshi Krishna, and Dr. Manohar.
Good morning, everyone. So we in the morning are talking about the nightmares. So I'll be taking to the other part, which is the second most common. I'll say this is the first most common surgery being done by all the urologists and across the age and across the institutes. And that is the TURP, now HOLEP or enucleation, whatever you say, but the prosthetic surgery is the one which is being done on the regular basis. So I welcome my panelists and my chairman also. They're all very experienced, so we'll have discussion. So HOLEP, TURP, enucleation, whatever you say, the prosthetic surgery, the gold standard, it is now becoming the gold standard. Endoscopy is the gold standard of managing BP or BOO, as we say. But when we operate, we have accidents and we'll have nightmares. So to discuss what can happen, the aim of this session is about to discuss what has happened and how to come out of it safely. It is, and believe you me, all these complications, whatever I have collected is from the senior most people in urology. It is not by the juniors, it is by the seniors. So sometimes you believe that TURP is a routine surgery, like a straight road, but it is not. It's like this. If you are able to manage, well and fine. If not, then you're in trouble. So the basic aim is to come out safely of the things. So what can happen? When can it happen is important in TURP, because if it happens in the beginning, what you do, middle of the procedure, what you do, and towards the end, what you do. Can it be avoided? Sometimes not. So the purpose is, what are the options with us? So why are we afraid of a complication or a nightmare? Complication is still manageable, but nightmares are sometimes, very difficult to manage. The problem is the patient's attendance. Once you come out, they want to see you relaxed coming out and saying, Doctor, everything has gone well. But sometimes that's not the case. You have to, you're working in a corporate hospital, you have to go and answer to your seniors or to the people there. There is a Consumer Protection Act. So once this happens to you, sometimes your mind stops to work and your reputation is at stake. And the best are your colleagues around you. They can do a lot of help in spreading that thing around. So intraoperative, the nightmares can be intraop, you're doing it and you can get a nightmare, or it can be post-operative, you have done a very good job, you go back and suddenly you get a call, Doctor, this is happening, come rush back. So it can be immediate, or the patient can come after some time with the things. Whenever you operate or give a cut, there is going to be a bleeding. So I just want to ask from my panelist, Dr. Manohar, how do you explain your attendance about a TURP? Your patient is sitting in front of you and you want to explain the procedure of a TURP. What you tell the patient? Do you arrange blood for the patient?
We'll just reserve, sir. All patients, if in larger gland, we are going to reserve.
No, large means what? Large
More
means
than
what?
100 grams.
More than 100 grams.
Yeah.
Dr. Vas, what do you do?
As such, for all the glands more than 80 grams, we preserve blood.
So
But
more than 100
rarely-
grams, more than 100 grams, you say blood, arrange
more
blood,
than-
keep it ready.
More than 80 grams. We keep
More
the
than
blood
80, you keep ready. And you
But-
do more of a thulium laser,
Yes, sir. We have more of.
So laser or TURP, you keep that ready.
Most of the time, we don't keep blood for enucleation.
You don't require something different, but that is what I'm saying. You are prepared. You have not explained to the patient, or you explain every patient that it may need blood.
Sir, for a large grant, when we are doing planning for TURP, we usually explain for transfusion. But in case of after gaining experience in enucleation, of late we are not explaining clearly that we might need blood transfusions.
What do you do in your practice? Do you explain with your experience? What I'm saying is, because
Yeah.
bleeding,
So
you don't never know which patient. will
Bleeding
bleed.
per se is explained to every patient. Blood is not arranged even for 200, 300 gram prostate. But if intraoperatively, I see, being in a corporate, there are some advantages also. If intraoperatively I feel that he is bleeding more, I quickly send for a cross match and check for availability, which can be arranged.
Correct. I think that is a better way to go. And especially for all our roaming practice friends, you should always explain it to the patient that you may need blood. The nursing home fellow may not explain, but as a surgeon, it is your moral responsibility. You may tell just passing remark that you may need blood. It should not come as a shock to the patient that the patient is bleeding. Now, this is one of the being done by the lasers, and this is a bleeding. The simple bleeding point is there. So with the vision hampering, what are the options you have? What do you do with this? If you're not able to see it properly, it's coming to you. What do you see? What do you do?
we'll try, come back and try to move the different.
So what are the tricks you follow if it is bleeding and you're not able to see properly?
Bleeding, first initially when you're getting the bleeding, you increase the flow of the irrigation.
You increase the flow of the
Flow
irrigation.
and
And
ask
for
the-
how long would you do that?
Sir,
For how long would you do that?
for 5 minutes, not more than 5 minutes.
Not more than
Not
5
more than
minutes.
5 minutes.
And
Even after, if you're off, even after 5 minutes also, if you're not able to control that bleeding, then better option is then can change you to loop and can coagulate this.
so you want to change technology from this to you
Yes,
can do
yes.
this thing. Anything you want to add, Dr. Manor?
So first thing is whether any outflow is blocked or not, check it. And come back, best thing is take the resectoscope, go to the bladder.
And then
So, and
withdraw
come back
properly.
and slowly identify the bleeder.
That is
and
fine if
try
for a
to
small
coagulate
bleeder,
or-
but I don't think that will work for a large bleeder. So, but for a smaller bleeder, this really works. That is not an issue and you can get away with it. There are a lot of, the bleeding is primary or secondary sometimes. So as we were discussing to arrange blood or not to arrange blood, this is what literature says. Literature means the people who have worked for a longer span of time and longer number of cases, even they have a transfusion rate of 0.4 to 7.1%. For a primary hemorrhage. So again, coming to stressing the point, you should explain bleeding as a complication for TRP, whatever your experience may be, or whatever technology you may be using. And similarly, the secondary hemorrhage is also very high incidence. And what do you do for you sometimes technology changes and you say bipolar versus laser versus thulium versus holmium, still it can bleed. And doing a vaporization versus a enucleation or anything, still it can bleed. So bleeding is an inherent complication of any cut. So we should be prepared that the patient may bleed and we should arrange for the blood. So this is what, again, the literature says the difference, there's not much difference between bipolar and the monopolar TRP. So, and the laser in this case is not showing, but I'll come to the later slides. So this is one of the options for smaller bleedings. So if you have opened up a major sinus, Dr. Santosh, what would you do for that?
Dr. Vamshi.
Sorry.
Dr. Vamshi is.
Dr. Manis, what would you?
No problem.
It's a major sinus has opened up. Somebody has reported a prostate. See, sometimes the ultrasound plays on our mind. Somebody has reported a 70 grams prostate and it is not 70 grams and you prepare your cut according to 70 grams and you've taken a cut and there's a big sinus has opened up. What do you do?
So usually I've been practicing laser enucleation, thulium
Okay.
laser enucleation.
So,
So it is more likely to have a sinus opening in laser than TRP, I feel, because in TRP you go from superficial to deep. Laser you have to be on the plane where you encounter sinuses from the beginning.
sinus is open. It is bleeding badly. What do you do?
I have my experience, no kind of coagulation is going to stop a big sinus. If it is a sinus is always big, no muscle is there, no media is there.
Perfect. What do you do?
So-
urologists, we know it will not.
So I'll see how the patient is. The patient
Okay.
is a high risk patient. There is a lot of job to be done. Then I will call it a day and then put a catheter, give traction and explain the family that I'll call it a day and then I'll come again and see, relook, depends on
Right.
status.
So you
If-
put a catheter, what French catheter and how much do you inflate? the
Hematuria
balloon?
catheter. If there is a significant bleeding, hematuria catheter 24 3-way.
24 3-way, not available.
No.
It's not available. What do you do?
So whatever biggest size which is available, I will be using.
And inflate the balloon to what levels? You
Inflate to
put
40 cc.
40 cc and then
Yes.
you give it traction.
And I give a traction and I maintain the traction. And usually it is at least for 4 to 6 hours.
You are
and-
lucky. Usually it stops, but it is not stopping. Now what do you do?
My experience,
It
luckily,
stops.
I
You are
have
lucky.
not seen any
You are lucky.
venous sinus that is not venous sinus. I'm not talking about an arterial bleed. You have to coagulate all the arterial
So what I'm
bleeds.
saying is it is not because once it is bleeding badly, you try to coagulate, it opens up further and you make a mess of it.
No, I'm
You are-
not
you are
going to
absolutely
coagulate.
right. You are
I'm not going to coagulate it further.
So-
If I see it as a venous sinus, it's
But
done. I'm
sometimes-
not going to use any energy to close it. So I'm lucky that's why I'm telling, I have never seen
You have never
a
seen.
venous sinus.
Pray to God you never see that. What do you do? If it's not stopping Manor, what would you do?
So first thing is.
It will
we-
happen someday.
Yeah,
So-
we check out the coagulation, any parameters are different, then the best option is to open if the severe bleeding. And you have to pack the fossa. First try, before packing, you identify the bleeder, try to take a stitch at the 5.
You will
7
not
or
be able
10.
to take a
If
stitch.
you're not able to see anything, try to coagulate. If not possible, you first put a catheter, 24 catheter, and along the side of the catheter, you have to try to pack with a ribbon gauze. We had two cases. It was a very badly bled. So we able to pack the fossa completely, and we try to get out from the small, it should be around 1 inch, not more than that. Take out from the bladder and take out from the outside.
Fine. Dr.
And
Chandar,
give a traction to the.
have you ever had an experience like that? You need to pack? No.
Generally, frankly, I'm speaking, leave that area, go to the other area and do it. Observe the outflow. If you keep on flushing there, blood may come out. So what I do is go to other area, do the surgery. If it is still not stopping, Foley's catheter and whatever there. If after that also I have not encountered, I depend on a Thamslet. I keep if the blood pressure is very high, I will control. These two, vitamin K, it's not recommended, but what I am saying is these two I will try. After that, I have, as Vamsi told, I have not come across, fortunately, blood transfusion we will give. What next is difficult to imagine. You have
So
to
no,
tell
no,
us.
fair enough. So this is just for the teaching purpose that packing, one should not, be afraid. We do it because we have to do sometimes the open prostates. We don't have access to high power lasers in medical college. So we do sometimes open prostates and they bleed very badly. I agree with you that for endoscopic procedures, 99 out of 100 times it will stop by this thing. How to pack is important. You do a cystotomy. You just place a catheter, don't inflate the balloon, pull the catheter through the cystotomy, go on packing with a ribbon pack. It is tightly packed. Take out a ribbon gauze separately. Now inflate the balloon, give a traction and put a SPC. So that and after about, you'll be surprised at about 36 to 48 hours under good analgesia, you start withdrawing the pack and the patient usually does well. Yeah.
Yes.
Yeah.
So fine. That is what I'm
Also,
saying.
sir,
A
if I
nightmare
can-
means
I-
nightmare means it is not stopping.
the
So for a
situation-
complication means you will get over it then and there. But nightmare means you want to stop. You have tried all your options and it is not stopping.
Just
I
one
was
point
about to
regarding-
complete. If the patient is sick, the lot of job is to be done.
Yeah.
Then you will
fair
do.
enough.
Yeah,
Fair
yeah.
enough.
If patient is fit and there is a little prostate left, you can
Even
complete.
we are
the job.
talking about packing. Even people have explained open bilateral internal iliac ligation. That is what has been mentioned in the publish. That has been published. Fortunately, none of us has done it, but that is
This
one of the
was
options.
happened in, this was happened in TRP, sir, in a very big land.
Okay. So now, yeah.
We will listen from Ramesh sir also, who have more than 30 years of experience
Yeah, sir.
in the institutes. Have you ever needed open surgery and packing after TURP, sir?
And
Yeah. That's one second.
so, so that is why I'm saying it's a nightmare. So for the juniors, they have to understand that if you are packing, you're not doing something wrong, and majority of us would not know how to pack.
Yes. Yes.
So that is my aim, to tell you how to pack. If that happens to you, pack. There is no
Well
shame in
taken.
that.
Well taken.
So
Well taken.
yeah, I take that one. Right. So
I did not even imagine till you said we have to pack in post URP. Now only I'm imagining. That's a good point for the.
so
If at all, if you are in a bad situation, packing is not a bad idea.
bad option. So perforation is the second most, after the bleeding, you may perforate, you may have a perforation. So this is the basic classification of perforation, how we can have threatened, covered, free or subtrigonal. So I'll take you, this is a simple index case, a standard case of 74 grams prostate. You may do a laser, you may do a bipolar, you may do a enucleation, you may do a standard TURP, whatever is good in your hands, you can do that. And can we have this video? Both the videos simultaneously. Excuse me, can we have the videos? Both the videos simultaneously. Yeah, this is a TURP being done, and we can see a clear-cut perforation. It's a subtrigonal perforation, and the opposite side is a laser, again a clear-cut subtrigonal perforation. So we can see that we can get a perforation in either of the technology. So technology does not make a difference. Sometimes this can happen. So these are the intraoperative findings. Now, what sort of prostates one expects, to have subtrigonal perforations? Manor, you do a lot of them, but TURP. So first TURP I'll ask, just straight question.
Majority of the cases will be very big median lobe. And
Very
the
big
s-
median lobe.
And the perforation will occur subtrigonal mainly because of introduction of the scope. If you're not able to introduce properly,
Yeah.
they can, especially
Exactly.
with the beginners.
That is my point to the
especially with
juniors. If you are just pushing your scope like straight, it is very high likelihood, because if you have the bladder neck fibers are there, you can get into subtrigonal. So you have to go a little down and then push it inside. So that is one of the tricks we should always remember once you're doing big prostates, and sometimes you would be doing big median lobes. So that is one of the things. And what error leads to perforation in lasers for Thulmium expert?
So during lasers, usually commonly we see the subtrigonal perforation when there is a large median lobes.
Again, large median lobe. So
Large
that is the
median
culprit
lobes.
for that. So the
And,
takeaway.
that also in the end of the when
Yeah,
we
yeah.
reach near
So the takeaway point is, so once you're doing a median lobe, beware that you can get a subtrigonal perforation. And since sometimes you're doing the median lobe at the beginning of the things to get a good flow, inflow and outflow. So if you get it, you should be aware of it, that you are having it. So this is one of the perforation videos being, I have also been given by one of the senior people. And this is a clear-cut perforation which has happened once he's, trying to enucleate and trying to push with the beak of the probe, and this is perforated completely. So this is the situation. So now, sometimes what happens is you have done a good job, you've done a traction, and you are in the OPD, started your OPD and doing things, and you get a call from the assistant. He says, the doctor, the patient is not very comfortable. He is very upset and he's complaining of pain because the effect of the spinal has gone. Now the abdominal rigidity has come. So in such situation, what do you do, Dr. Babu? What is your, how do you, what is the first line of investigation would you like to do?
when you take bedside
Ultrasound. If not available, bedside ultrasound, see, now you get a PNDT Act. So you cannot move the ultrasound from your OPD even to the ward. So if that is the case, and if you're working in a small sector, so it is fine. But if you're working in a big sector, so to get an ultrasound by the side of the table, I believe sometime would be hitch, if I'm not wrong. So what would you do, Dr. Yeah, what would you do?
I've seen many a times this kind of situation.
Okay.
So in the beginning, I was worried if this leads to some problems. I used to put a needle in the standard, the mid 1/3 of the spino-umbilical line, drain some fluid, and then
So drain some fluid with
in
what?
the initial parts, in the
No,
initial,
fair enough. With what? What do you use?
with a wide bore needle like a 14 gauge or 16 gauge Venclone.
With this fat fellow, this will go inside?
A wider needle, whatever wider, longer needle is available.
Bedside?
But later on, I found these are all extraperitoneal fluid accumulations
Okay.
which seep into the intraperitoneal fluid because of the excess volume. You can just observe these patients with a good catheter drainage, ensure the catheter is patent. In less than 24 to 48 hours, all this will settle down and patient will be comfortable.
So what would be your indication of putting a drain in the local anesthesia? Would you not?
If I am sure where the perforation is, like during the procedure, if I am the surgeon, I will be seeing where the thing has gone wrong. Most likely all the prostatic perforations, unless it's an injury during a morcellation where I am not sure the vision was
That is
poor.
something different. That is some.
So this is a
morcellation injury different.
prostatic
This is
perforation.
prostatic. This is retroperitoneal
Is
collection.
99% it is retroperitoneal. So I am looking for signs of peritonitis. If peritonitis symptoms are not there, it's only a distension, non-tender, soft distension, then there is no indication for any drainage of the abdomen.
So you don't put that. So again, the point is that don't panic with that. Reassure the patient, keep him under observation. And when you have some issue, it is progressing, you're not comfortable, take the patient back to the OR, and under a simple blunt dissection, give a local anesthesia, and you can just slide in a drain. That doesn't make a difference. Yes, Abhishek. Yeah, but usually. Yeah, fully agreed. So that is what I'm saying. If the patient abdomen is soft, and if the patient is clinically, you have to judge it clinically. And if you believe that the patient is not clinically comfortable, You'll come to know, you have seen the patient pre-op, you have seen the patient intra-op, and now you're seeing the patient post-op. And you'll get that sixth sense, that patient is not comfortable. You go ahead and put a drain under local, you don't lose anything. So these are all rare occasions, but putting a drain under local will not, harm the patient.
One thing, doctor, you asked about the choice of needle. I really prefer the PCNL puncture needle in these
Yeah,
cases.
that is
Because it
one of
doesn't
the,
have a beveled edge. It's very safe even if you manipulate it after you take
even
out the. Yeah.
there is a epidural needle.
Yeah.
It's a wide bore needle. You can place that also, but putting a drain, 20 French drain, draining the fluid, it does not make a difference. Now, this is one of the videos of a bladder perforation. If you see, this is a bladder perforation in TURP. A lot of people get surprised. Why do we, what has happened? So what do you feel, what would have gone wrong to have a bladder perforation in a patient? No, this goes to him because we have discussed already.
Maybe because of the large median lobe, we'll be dissecting the median lobe inside near the triangle.
Okay, one that's otherwise. No, not morcellation. This is a TURP. You can see a loop there.
During this section.
So what happened was, inadvertently, we asked the resident to start the TURP. He was standing behind him, and while adjusting the things, inadvertently he pressed the cutting switch, and the loop was not withdrawn. So the loop was outside only, and while adjusting the foot switch, he inadvertently pressed that, and that just perforated the bladder. So that is one of the points. Whenever you are doing a TURP as a beginner, always remind yourself that you have to keep the loop inside. While for an active system, you have to keep the loop inside. You don't have to, it should not be out. But then this is a perforation, and cause, site, and management we'll discuss. So second important component is morcellation.
Sir, one perforation I have seen during leaks evacuation in a old 83 years old man because of the gas distance.
Maybe, yes, that can also happen.
Also, I mean, just I'm adding.
Yeah. So intra-op morcellation, we have all, now the things are coming to the laser. Everybody's laser, enucleation laser. Last 2-3 years, I am seeing the TURP has taken a back seat. And so this becomes very important and prudent for all of us to learn how to do a decent, uneventful morcellation. I'm using the word uneventful. So this, I'm really thankful to Dr. Gopal. He has lent us this video, which is, can you play the video, please? So, and this comes from an experienced surgeon, comes from a good institute. So this can happen to anybody. So now suddenly you can't see anything. So this all has gone bad, and they have just gone back to see what has happened. And when they see there is a clear-cut perivesical fat is there, the bladder is completely perforated. So now the issue is what to do with these perforations. These perforations have happened. How do you manage them?
So most of these perforations, usually if it is on the tomb, usually it's intraperitoneal.
So what do you do?
If we intraperitoneal, better is to go and close.
Close.
Yes,
Do you do
yes,
something
yes.
different?
It will be
No.
close.
Anything different?
Nothing different.
Nothing. So there is no discussion on this. So what is done is, this was done in our setup. We just opened up, saw from where it is opened, and closed that. Similarly, what they have done is they have also opened up and 2-layer closure of the bladder, and the patient is fine. So initially what I started was, whenever you go inside and talk to the patient's attendant, don't show them the moon that you are going to do a endoscopic surgery. It is stitchless plus. Just passing reference should be that sometimes, very rarely, you have to do some other procedures for which you are not mentally prepared. Because if you have talked only about moon and you can't even reach the space, the things will be very difficult for all of us. This is again a video which has been lent to me by Dr. Maheshwari sir, and he is one of the very experienced laser surgeons in the yesteryears. He has started, and he's one of the best ones. And even the ureteric injury has happened with him also. So in what cases you expect a ureteric injury? You can do a lot of work.
First of all, I feel ureteric orifice injury for the same gland, it has a higher propensity with laser than a TURP. Because
Why
in
so?
TURP, we come from the bladder to the veru. In
Okay,
laser,
yes.
we have to go from the veru to the bladder.
So what do you do to avoid it?
So there are certain tips. The higher chances happen when there is a large median lobe. Obviously, the orifices are not visible. So if possible, whenever it is feasible, if we can in the beginning, we can demarcate, like we make apical incisions at the veru and the midline incision at the toe clock. We can
What lobe technique would you follow for a large medial lobe? You want to single lobe, or you want to do to be on the safer side? What would you suggest to a beginner?
Usually, if there is a large median lobe, I usually follow a 3-lobe technique, remove the median lobe.
That is
first.
what the point I wanted to drive at. So if you are starting as a starting person, if you are like an experienced person like him, you can do anything. But if you're a starter, you always start a 3-lobe technique. There is no harm in doing a 3-lobe technique. And if you happen to injure the ureter, your orifice is visible, you put up a stent, and usually the things will go by itself. You don't have to do anything extra. So now this is one of the very rare nightmares, and I hope nobody sees them. But there is a, as the patient has gone home, everybody is happy. So now he comes back after about 2 weeks down the line and he says, I'm passing fluid through my rectum. So what do you think would have happened in this patient? Okay. So he developed a fistula. Obviously he
there is a
developed a fistula. And just to cut the thing short, what would you do for the fistula? We have evaluated, you do a CT, standard CT, you can see a clear-cut fistula. So how do you manage such fistula?
Divert both the systems.
Divert both the systems. Anything separate you want to do?
Same thing. Divert
Same
the
thing.
System, SPC.
And wait for?
Wait for at least 6 to 8 weeks minimum.
6 to 8 weeks. So that is what was done here. This is a cystoscopic picture. So I'll just skip that. What was done was conservative. We can do surgical, open or minimal invasive like laparoscopy or robotic. But in this case, what was done was, it was just managed conservatively. So don't panic, explain to the patient this has happened and this would go off. If it doesn't go off, then only you go and do something different. So this is one of the last complications I would like to discuss. This is a penile burn which has happened to the patient, and it has appeared about 2 weeks down the line, and the patient comes with this. I don't know whether it is visible there or not. Here it is quite visible. At the meatus, it's all charred tissue is there, scar tissue is there. So what do you believe, what would have gone wrong, and how can you avoid it as a TURP resectionist? Because this won't happen in laser. This will happen
This
only
mainly due to we had one case in 2008, one case post URB. It's due to the defect of the loop. There is a sheath. If there is any defect, or where you join to the resectoscope, if there is any defect there, the electric current can transmit to the from there to
leakage
inner
of
and outer
current.
sheath.
So the leakage of current is very
Leakage
important.
of current, yeah.
And to
How do you identify that also, you please tell? Because nobody will test everyday current whether it is leaking. or
perfectly
not.
all right. So what we do is, what should be done for a beginner is, you assemble your resectoscope yourself. If you do that, you will find that the loop is not broken. You will find that you have slided it across, and you will feel that click when you put the cautery lid to it. If somebody else is doing for you, it may be loose, it may not be correct, and you are in a trouble. So as a protocol wise, till today, I always, and if I have any difficulty in the loop, the angle changes or that changes, I change the loop. It is better to change the loop than to have this problem.
Sir, have you ever noticed urethral thermal severe injury?
No, I have not, but that is
That's
also
what,
mentioned
sir,
in literature.
we had case in 2008, I was an SR. It was complete urethra followed by an skin was burnt.
So
my
since
God.
we
So
don't have the,
after that, over a period of time,
we have to stick
came
to the-
know that when we call the stores people,
we have to
that
stick to
time we
the
came to
time.
know
Yeah,
that.
I fully agree. So the important thing towards the TURP or the laser is that we have to see for the instruments what we want to use. What is the size of the penis? One instrument may not fit all the penile sizes. So invest into the scopes which are of smaller size, and lubricate. So no amount of energy, what source you want to use will make a difference. Use bipolar, monopolar if there is a current leak. If you use local loops, if you use the instruments which are not, the standardized, you will someday face this problem, and this will bring a lot of, bad name to you. You wanted to say something?
I know one of the case, even I think Dr. Chandramohan knows about this. One patient had a complete penile necrosis.
Yeah. So this is,
I think I want Dr. Chandramohan sir say.
It is published, we have published that complete penile necrosis leading to the total penectomy because he went into
so
sepsis.
that would be a
Total
real disaster
penectomy
for,
because entire penis has become black.
and the reason
As
was
a case report.
current leak.
Reason was immediate post-operative period. What happened? He came with retention. After that, black eschar is present. They did not do debridement. Another 10 days waited.
So that is it.
Diabetes,
And that infection
atherosclerosis,
and
coagulation,
penile,
all
a Fournier's.
aggravated. Primary is infection, but
So-
urethra also necrosed completely up to the bulbomembranous region.
So Abhishek, last two slides. So one is, don't be under this impression that lasers are the panacea for everything. They don't cause complication. This is a paper which has just come as a systematic review of 10,371 patients. And you can find all those complications which happen in TURP, enucleation with the lasers also. So take home message would be that complications happen to those who operate. So you don't panic, take help. There is no ego involved. Call to your nearest senior, ask him what is to be required. If he is kind enough to come to you then and there, he will better be, his mind is fresh, he can able to guide you better. Learn from them. The important thing is don't repeat the same mistakes, and surgery is just learn to navigate. It's not a straightforward thing. Thank you very much. Thank you. Thank you, panelists, and thank you.
Thank you, Dr. Rahul. Thank you to the panelists, and many thanks to Dr. Chandramohan and Dr. Said for chairing the session.
Now we move upon to the next session. This is a special YOU invited lecture session. Now we call upon Dr. Said bin Hamari, consultant from Saudi Arabia, to deliver his lecture on miniaturization of RARS. I call Dr. Chandramohan Reddy, Dr. Tanishpal Bhatia to chair this session. Thank you.
Thank you very much. Dear respectable friends and colleagues, it's an honor and privilege to be in India, where the great hospitality mixed with a very nice flavor. You have a great country. Zishan asked me what subjects by hazard that I found the tightest ureters in the world are Indians. Maybe some people were discussing over the world. So I would like to just expose what we have in the future for small uteroscopes. I declare that I work with these companies, and all videos you're gonna see. So why we need a small endoscope? I just divided them 4 categories. Primary access, you have more successful to achieve ureteral access sheath, pediatric group, and anatomical variants. First one, you know all that the most common and the best seller scope was the 7.5 Flex X2, not because of the image, because of the price as well as the size. It is 7.5 comparing to the digital 9.9 at 2010 by Olympus. Wolf came down 9.9 to 8.7 even with the digital. So they improved the image and they improved the size. Olympus P7 is the smallest ureteroscope in the markets, where the conventional and reusable scope, it's a 7.9. Imagine that you have something 8 French with a tip of 5 French. So you can use it in a very tight ureter. So you have a more success rate to achieve to access the ureter. Disposable uteroscopes, even in India, the endoscope DPRA changed from 9 French to 7.5 because those companies comprehend very well that you need an access and you need a smaller scope. The working channel is a 3.3. Flexible uteroscope, disposable, they are competing between 8 to 9. Most of the companies, especially Pusen, 9.2 came, the improvement image came down to 7.5 because they abandoned the size of 9 French. If you look very carefully, this is the semi-rigid of Olympus, where the tip is 6.4 and 7.8 the shaft. So this must be smaller than 7.5. HugeMed, another company, you have in the market 2 disposables, Pusen and HugeMed. They have a 7.5. This gives you an idea, not only caring about the vision, the size is very important. The image is comparable to the digital. What about the semi-rigid? 12 French, maybe 10 years ago, 15 years ago. You have a rounded and atraumatic design. And you have the smallest scope semi-rigid from Wolf. It's a 4.5 French. It means 1.4 millimeter. So your high access, primary access is very high. You have a sequential size, 4.5, 6 French. So go below 6.5 and 6 French. Double channel has no benefit nowadays because you have to use a laser if you are needed. So this, you have to sacrifice by the accessory channel by reducing the size of uroscope. You can see this is a 4.5 with a working channel 3 French. 3 French means 0.9 millimeter. You can put a laser fiber 200 micron, you can put a laser fiber 365. Why we don't use a large semi-rigid? Because of these kind of perforation. If you are a beginner or if you are overconfident, you can do a perforation by pushing the ureteroscope because you want to finish the patient and you are in a hurry. And the patient family outside and you want to see yourself, that stone is there, so I have to get it. We are forgetting that this larger scope is not the starting 8 French, but the shaft is 9 French. So it's a sequential increasing in the size. You might ask yourself, I should do a balloon. Imagine that these ureters in the distal size is a 3 French to 5 French to 10 French. If you put a balloon, which is a 15 French, you are traumatizing the ureter. So we are not anymore adapting our patient to our instruments. We have to adapt our instruments to our patients. This is a 7.5 French inside the virgin ureter. You can easily see that you need to prepare ureter for a 9 French or 8.5, but you have a smaller scope, you can easily go without an access sheet and finish that stone. Second is the ureteral access sheet. Ureteral access sheet, we have many in the market from many companies. What is the size actual, like 6 years ago or 8 years ago, it was at 12, 14. Nowadays, what trend is going to the access sheet down to 10, 12. What is the advantage of access sheets? It gives you the multiple in out, decreasing operative time, and the most important is to reduce the intrarenal pressure. And this is the most important factor in urology. If you're doing a semi-rigid, look how much pressure you are putting in this study. The pressure inside the kidney is between 35 to 45. And if you are using an access sheet, you will decrease significantly the intrarenal pressure. This is a study from Brian Isner from Boston, where he showed that the no sheet having a high pressure comparing to 10, 12, and then the 12, 14. You will ask yourself, do we have an access sheet 14, 16? Yes, we have an access sheet 16, 18. Believe me, the ureters in Germany are not ureters in India. So this is a picture that will show you that if you are not using an access sheet, you will apply a lot of pressure inside the kidney. And this will be recognized by intraoperatively. So what about putting the scope inside the access sheet? You will be able to retrieve the stone, but the degree of pressure you're applying on the kidney is unmanageable. And I will show you something. 14, 16, you have a very drainage. If you put a flexible ureteroscope 9 French inside it, so you will have more irrigation. What you put in, you will get it out. But if you put a 9 French inside a 10 French ureteral access sheet, you will have only 1 French for the drainage. So that will create a much pressure. So what is the point here? The point here that you reduce your access sheet size by reducing your ureteroscope. And this is the first point. So the first point is to reduce the ureteral access sheet to have a more pressure and balanced pressure. This is a 9.2 comparing to 7.5. Look, if you go to smaller scopes with the same size of access sheet 10, 12, you will have more balanced pressure inside the patient. We know all the story about the Traxer paper, which I worked with it. And if you dig in that article, you'll find 86% of the patients, they have a grade 1 lesion. And this will give you an idea, 12, 14 access sheets give you this kind of injuries. But what about perforation retroperitoneal? What about submucosal? What about complete flap? Look at this injury. It happened to me. Then I was shocked how this access sheet could do such injuries like an open book. But amazing that it's upon the experience opinion, these kind of longitudinal injuries is not like the circumferential injuries. This is 4 weeks later. So we are lucky to have a healing, but does not that mean you have the courage to put an access sheet 12, 14 because your scope is 9 French. So the idea here, whether you prepare your ureter or do not force it or use a smaller scope. Look at how much pressure and hematoma in the unprepared ureter. You can see the pressure. This is only 70 minutes. And this is where the idea comes from. The ureteral injuries depends on the operative time and the size. We did a study in our center. Why we do 12, 14? Let's go for 10, 12. So we want to see if the injuries, 46% by the group of levetiracetam by 12-14, how much it went down. If you use a 10-12, you are reducing the injuries by level of 12.4 instead of 46%. And this is gives you an idea. Go smaller to reduce the ureteric injuries. The question here, if you have a small scope, you have a small ureteral access sheet, do not forget the space between the access sheet and the flexible ureteroscope. In PCNL, I believe it's between 3 to 4 French. In flexible, you need at least 2 French, 1.5 to achieve such dusting of a 3 centimeter stone. You can have different things, different strategy. You can have a wise irrigation, ureteral access sheet 11-13, endoscope of 8.7, which means gives you about 2 French to dust and achieve something in the retrograde intrarenal surgery. This gives an idea about the new laser. Sorry. This gives you an idea. If you have a smaller scope, smaller uteral access sheet, finer dust done by a special laser, and drainage and balanced pressure, do we need to do basketing? Do we need to do many more of mini perk that's been done for 2 centimeter or 1.5 centimeter? So you're playing with it. Should I continue? So the third point is the pediatric. We know in group of Singh from New York, he presented in 2006 an access sheet, 12-14 French, with no problems and no, and with the age 4 to 15 years old, 12-14. Imagine that you put a 12-14 access sheet inside the ureter of an infant with a stone size 14. But what about if you're reducing an access sheet? Some people will say, how do you put an access sheet in 2 years old? This is a 2 years old ureter with an access sheet 10-12. So do we need an access sheet? No, you need just an ureteroscope of 7.5 to achieve some miracle. 12-14, you can put it in 9 French. Above 6 years old, you can easily with the pre-stenting. We know that in the pediatric group that pre-stenting increased the success rate. This is a 14 millimeter stone in a 6 years old, dusted easily. This is a bilateral ureteroscope with a fine endoscope, 8 years old. This is an 18 months baby, 1.5 years. Look at the 7.5, how the deflection inside the very small kidney. This is the 2 years old. You can see the easy access inside the ureter, no access sheet. The stent was there for a certain time. And then 9 millimeter stone is done. Bilateral uteroscope, easily you can do for pediatric. And even if you failed with the PCNL, we know that 16 patients, this is a 10 years old who had 4 PCNL, 3 uteroscopies, and you can easily do with the small scopes and without harming his parenchyma in 2 stages or final stage. This is a kid, 11 years old. He had injury grade 2. You can see the muscle by 9 French. 4 weeks later, we like to explore the ureters that been injured. That's why I always say to my colleague, go and see these lesions, how do they develop, and follow the patients. So the question here, why we use a 9 French in pediatric group and we have a 7.5. Fourth element is the anatomical variance. Look at this very tight infundibulum, not easy to incise the diverticulum. You can use a Flex XC, which is 8.4 with a fine tip, and you go inside the verticulum and you finish that stone easily without hitting the laser. What about if you have a very small, tight infundibulum? You can incise a little bit of the neck, short infundibulum, and then you hit the stone. What about if you have a long infundibulum? Look at this. This is very long infundibulum. I believe we were discussing the PCNL. This is the infundibulum. The laceration inside the infundibulum going to the long infundibulum to the 2 calyceal system. So it will give you an idea, is 9 French or 9.2 French will do the job as if you have 8.4 or a 7.5 French. Pearson, 7.5, in tight infundibulum, look at this, 9.2, that successfully went inside with no problem. Look at that video, that we could not get inside the infundibulum, we changed it to 7.5, and we went into the stone. And this will give you an idea. The small size is not only for the ureter, it's inside the kidney as well. The take-home messages here: anatomy versus instruments. You have to adapt your instrument to your instrument to your patient, not your patient to your instrument. Go smaller. Size is very important. Pre-stenting is not preferable. I know some countries in Europe, they do pre-stenting. With the new mini ureteroscopies, there is no pre-stenting anymore. Remember the pressure and flow if you're using a mini instruments, and they are vulnerable to be broken down. And as always saying, every French counts. Thank you very much.
Can we ask a question?
Yeah, please.
It's very good talk, very comprehensive. Just one question I wanted to ask: what difficulties I find in a pediatric RARS is that the efflux of the fluid is not as good as it in the adults. So what are the tips for doing a pediatric? See,
Come again?
What I'm saying is that once you're doing a pediatric case with RARS, the efflux, the inflow is fine. The fluid, the visibility is not that good as it is the adult kidneys is.
The
This is
return
my
is not
experience.
as
So,
good. The
This is-
return is not as good, yes.
yeah,
The return flow is not that.
in hampers. So what do you do?
So I believe those small kidneys, they don't have enough irrigation. So you will have a very slow. You have to be patient, and always I prefer pre-stenting in the pediatric because this will enlarge a little bit of the space. They have very small kidneys, so the vision will not be perfect as this. So you go by smaller, and you don't use an access sheet. Sometimes if you have an access sheet, you use it, but slow with the irrigation. If you put a lot of irrigation, the space is not like an adult. It's a challenging as a pediatric. I know in the IRS, the pediatric.
That is
I'm
why
sure.
I thought it's with me only. Okay, thank you.
That is an excellent talk, Syed. Here, Chandramohan.
Oh,
Yeah.
sorry.
So what is the, why we are not able to go access sheet below 9.5 French? Is it because the scopes are not available, or
Why we go below?
access sheet less than 9.5 not available in the world?
Yeah. Well, that's because I think the companies, when we discuss this one, it doesn't worth it because it depends on the scopes. 9.5, 11.5 from Cook, one Geotech
Is
from
the last.
Turkey was the only thing because it was adapting 7.5 from stores. But most of the scopes are 9 French, 8.7, which does not include. For example, I will tell you a story. I did a study P5, which is the Olympus saying it's 8.4, 8.4. The tip is 6 French. It doesn't go inside 9.5. So why the companies doing a smaller access sheet while the ureteroscope are bigger? And this is the point. 9.5, 11.5 was made for Flex X2. P5, maybe P7 can go, but P5 doesn't go. But the benefit, why I put an access sheet 9.5, I can put an scope directly 9.5 or 7.5. This is the question. There is no benefit.
Have you ever felt that a guide wire by the side of the flexible scope through the access sheet, it will be helpful? Do you ever felt that guide wire by the side of the flexible scope through the access
Inside
sheet?
an access sheet.
Usually it doesn't go. Did you ever feel the need of it? And recently, to my surprise,
You mean a guide wire outside the access
As a
sheet?
safety
No.
guide.
no. Guide wire through the guide wire and flexible scope both together through the access sheet. Usually it won't go.
Yeah,
When
because
I
you need
was
a
doing
space, 1
anti-grade,
mm.
when I was doing anti-grade flexible scopy, I was desperately needing it. I passed by the side of the huge bed, it went.
Yeah, because you've got the smaller scope.
Huge bed is the smaller than Poussin is my, because our topic today is miniaturization. You have already used huge bed.
Yeah, I have it.
You feel it is
It's-
small.
Yeah, it's a small, it's like, looks like a 7.5, but the flexibility is more with the huge mat.
Yes. We also felt like,
Yeah.
because the topic is that, and they are claiming now that it is 7.3 French, not 7.5.
The idea with the endourology market now is going with the small scope rather than going with the small uteroscope.
So in your
Because
experience, do you think that it will go further smaller?
where? The urethral access sheath? Urethral access
No,
sheath?
scope.
You never know, because in Maxiflex, which is an American, it was 6 French, but it failed because it's reusable. And when you go down with the size, it's more vulnerable to be broken down. And this is the problem. When you go smaller, it's be broken. And you know, the words, it's to be a heavy car, you need to be ranging between 7 to 9. And 6 French is very promising, but I don't know if it's calculated. Pucin, when they start 7.5, they had many problems because of the durability and the broken, because once you use it, in the beginning of half an hour, it's broken. So they modify it more and more. So I think there are a chance to go down, but they need to be good to do it.
One more important point, because you have been into the research of these flexible scopes. Do you think that the smaller flexible scopes is possible only with the digital scopes? This is my question one. Digital scopes only becoming smaller. Digital scope only becoming smaller. Unlike previously, digital scopes are bigger. Now all disposable scopes are digital.
True.
They are going smaller.
True.
And do you believe in disposable future that it will be used only once, or it can be reused? Because this is a common question
Listen,
asked in India.
You are the master of, we call it hybrid uteroscope, like DIPRA. DIPRA is doing you 20 hours. So this is in between. I don't believe in disposable because it's costly. Like in the 2/3 of the world, they cannot afford one use.
Great.
But if you can do one uteroscope, very small, digital, hybrid, you can use it for 20 operation. Why not? This is
Great.
the future.
So that's
And I
happening in
believe-
India. It's a
I-
future.
I believe, yes, I believe there is no any more conventional. It will be all digital. It's a very fast.
And if you don't mind, what sterilization you are using for the smaller scopes?
What sterilization?
Sterilization.
Sidex. Chemical sterilization proved is the better than the
It's
plasma
For
steroid.
the juniors, lot of people are asking, see, a person with a lot of videos and lot of research says that chemical sterilization can be used for the so-called disposable reusable scopes.
True.
So this will change the entire scenario.
ETO is being banned from United States and from my country. And we use plasma steroid for the flexible cystoscope, and we use the chemical sterilization for the flexible uteroscope because it's a very fine scopes.
Okay.
Recently, there was advisory from Carl Stores, I guess, regarding the use of Sidex for
Yeah, but
sterilizing.
that's for the reusable, the
They
fiber
are
optic
not
scopes,
yet
which they
launched
are.
in India. They are keeping it. They will say, being a international company, they will say it is disposable only. One case. Whereas, yeah,
No, what he's
please.
saying is some
Abhishek?
scopes have been withdrawn. You're
Abhishek,
talking
you want
about
to comment?
that. That's a specific design.
Sir, I don't
They have
want to
withdrawn
comment. I
that.
want to ask a quick question. This is regarding temperature. As we miniaturize and the access sheets also goes down, our and your lab experiments both suggest that the flow going to less than 10 mils and the power going more than 30, the temperatures will definitely go more than 50. So what
True.
is the understanding
True.
at present?
That's why in case of TFL and high power machine, you have to maintain irrigation with the cold water. In the third low power machine or intermediate machine of the holmium, you give a temperature water, but it's very true that's been published by a group of tracks that you need a cold water for the, once you go down, you need
what
more
See, 1 minute is
cold water and more irrigation maintained. You're right, because it might go to 50.
Yeah, in country, yes, sir, please.
Chandram, on your point about why the digital scopes are becoming smaller and the fibroscopes are not, it's simple because the digital scope visions are much better and they're able to miniaturize the digital scope.
True.
Second is the costing of the digital scope, if you see over the last 3 years, has come down significantly.
True.
And I anticipate that as more competitors come in, the costs are further going to come down.
Yes, yes.
And we'll be in a time where even we will start disposing these scopes. And these locking mechanisms of duration, it's made by man. I mean, it's not the scope. So they have devised a lock. Now most of the companies have removed that lock.
Yes.
So they can use it indefinitely as long as the scope works.
In
Yeah,
continuation,
so
yes, sir,
actually those
agreed,
scopes don't
completely.
work for 20
The-
hours.
Continuation of the Abhishek's question.
The funny part is stores is doing disposable because they told now stores, the company of the reusable scope, they did their flexible disposable. It's 7.5. They want to go in the market. And
Yes.
I believe those companies, if they are not moving to disposable, I'm not saying disposable, hybrid, it will be done.
So we are finished with time. Last question I am asking with permission of Abhishek. This is 2025. Temperature regarding Abhishek has mentioned, most of the times when you are doing surgery with popcorn more than 30, even your hand is feeling the hot warmth. That time, many of the papers saying that if you, especially elevator exercise, you stop and restart for 10 seconds and make sure that the irrigation comes down properly. You can get away. What is your experience of raised temperature, especially with TFL in the RIRS?
Well, as I always saying, if you have a good irrigation and a normalized temperature or a cold water, you have no problem. In TFL, it's true that you have to stop from time to time. But if you are having a very experienced surgery in the IRS, I think TFL wouldn't be a problem for you. But for the beginner, I agree, you have to stop and see what's going on because it's a new technology. It's not, holmium laser was there for 25 years. So it was the footest than the earth. So the TFL would needs 10 years, 15 years to be on the ground because the training is increasing. The young generation is exposed to more operation and more surgery.
Yes. Thank you very much.
Thank you
And
very
that's
much.
an excellent answer for the
Thank
younger
you.
generation.
Thank
Thank
you,
you very
Dr.
much. An excellent talk. He came all the way from Saudi Arabia and given this talk. Excellent demonstration
us
of the
on.
videos also. Nice talk.
Thank you, Dr. Said, for that lucid talk. Now I call upon Mr. Nitish Nayak, Professor, MIT Manipal, to deliver his talk on technological innovations in 3D printing.
Everyone, delegates, thank you very much for inviting me for this talk on technological innovations in 3D printing to give a newer dimension to patient-centric treatment.
Slides are not moving. Press the big green button with the play sign.
Thank you. The contents we will discuss today, what is 3D printing technology, how this particular thing works, and the different types. There are many types of 3D printing. We will discuss few important types which are commonly used and the entire process behind the 3D printing. When we said it gives a newer dimensions, I have selected few topics wherein patient education might be surgical planning or surgical training, or if you can do surgical tools or prosthesis or the bioprinting. So what are the future directions which in 3D printing we need to look onto and the references? So when we say 3D printing, it's a common term which is generally used because people do the printing in 3 axes, you know, 2-dimensional, 3-dimensional, X, Y, and Z. So it is a terminology which has come with the time. Generally, in our engineering terms, we call it as additive manufacturing. Generally, the manufacturing technology, the how you manufacture the product depends on different methods which you can utilize. Wherein here, the additive manufacturing, you add the material layer by layer to bring a shape, a 3-dimensional shape to that object. Whereas generally in industrial engineering, you have a block, you remove the material and reduce it to give that shape. Whereas in 3-dimensional printing, you are adding the material layer by layer. So this generally was used by engineers or to develop a rapid prototype. When you want to iterate and bring in a new product, always there will be iterations. So you look into developing it faster, but to develop a prototype, okay, with the regular process, you need to invest a lot on the tooling arrangements. So this particular technology helps you to develop it faster. So it was slowly moved on to the healthcare, wherein translation of medical imaging, okay, the DICOM images which comes from the CT or MRI, where we were able to develop the patient specific anatomies like the bladder. When I speak to urology, maybe bladder or kidneys or replicas of it. So technology has emerged as a versatile medium in medicines, and it is ever expanding. Does 3D printing represent a valued and valuable adjunct to urological practice? This is the question which we need to discuss today. We will look into it. So how this works? So the image which you can see here, it has a filament. Generally, it comes as a filament which you use. It may be biocompatible filament, or it may be made up of PLA or ABS. If you are doing a medical instrument, you generally go with ABS filament, because when it is a prototype, you look into it to be much cheaper. Do it faster and it should be cheaper, because you never know, is it successful or not? Is the shape which is coming out, is it good or not? To look into that, this is the basic technology, okay, wherein you have a filament and extruder, and you have a heat bed also. We call it as a build platform, on which you are adding layer by layer. So the filaments spool through the extruder, through the heater block. So your filament is a solid, it's melting, and through the heated nozzle, you are building it on a build platform or a heat bed on which layer by layer is added. So how this particular system understands how it has to add in X, Y, and Z direction. The spool is like a pipe, okay, a wire which has to be melted, and the final product is what you imagine. How do you tell it? So different types, the 4 types which we are going to discuss: fuse deposition molding. So you need to select an appropriate type of a 3D printing process based on the application or the product which you need to have. So which one is better is always the question. So we will discuss 4 types, and then we can decide for our type of application which type of 3D printing process is much suitable. So 4 types which we are discussing today is fuse deposition molding, commonly termed as FDM, stereolithography, SLA, and selective laser sintering, SLS. So once we discuss the second and third one, we will know what is the difference. And the last one which we are discussing is polyjet. Fuse deposition molding, okay, the one which I showed earlier with the spool, it is fuse deposition molding. You have extruder, B is shown as a nozzle, C is your printed part, here it is a block. It can be any shape which you want to. You have a hot plate or the build platform, and E is the filament. You can see X, Y, and Z axis, 3 dimensions, because we call it as 3 dimension because you are able to print it in 3 directions. So fuse deposition molding, commonly a desktop 3D printing technology which uses plastic parts. Okay, FDM printer functions by extruding the filament layer by layer onto the build platform. Cost effective and quick method of producing your physical models. So where we lack here in this type of particular method is the surface finish, which you get is relatively poor, and it lacks strength also. It is a brittle type material. If you apply some pressure, generally it is tend to be broken. SLA, you can see the laser source and the mirror. What happens here is, again, the concept is same, but you have a liquid resin, which when a laser source is falling onto it, what happens is photopolymerization starts. So when you have 2 components and you bring it together or mix it together, there is a chain reaction which will happen to build that material. That's what it happens here when the laser source is supplying a low rated heat. Okay, the photopolymerization happens, because of which, okay, the material or the shape which you want to desire, you are able to get. So producing parts with higher accuracy, higher surface finishes, tight tolerances, okay, exactly the shape, okay, not very small, not very big. What shape and size you want, you are able to get. Okay, widely used in medical industry. And when you plan to do some anatomical models, okay, you can go with this. Selective laser sintering. The previous one was SLA, and the next one which we are discussing now is SLS, which we term as. So what happens here is, unlike the resin which we had used earlier, liquid resin, here we are going to use a powder. So nylon based powder into a solid plastic. Okay, so the same mechanism where you use a laser beam, you supply the heat, but the powder, which is nylon based powder, it melts and solidifies, you are going to get. So in comparison with the SLA and SL parts, these are stronger and have better surface finish. Prototype designs which you generally make, okay, when you want to, the last what we say is injection molded. Okay, when you are going to produce the components in large number, okay, generally we go with injection molded parts. It is the same shape and large number of components, injection molded. So generally, if it is a prototype or less quantity in number, okay, 3D printing is preferable in our manufacturing industry. But when the quantity is more, okay, then this method, when we talk about economics, is it economical or not, or whether it is time consuming to produce? Obviously not. It takes a lot of time. Further, if you want to produce a large number, we go with the different technologies or manufacturing methods. The one which we use generally is injection molding. Polyjet, this may be of interesting. Why? Because you want to have colorful models, okay, different components having different materials. This is one. It can be polyjet because it has multiple nozzles wherein you can use different materials with different mechanical or physical properties. Okay. So designers leverage this technology, prototyping elastomeric models. Okay, if you want to make a kidney, okay, it should be flexible. Okay, go with this particular method. So you can have different calyx with a different shape, the outer one with a different color. Okay, all these things you can do it, wherein generally it may be very useful for you to use in surgical training or training the residents or students. So if your design is single rigid plastic, it is recommended to stick with the other methods. But since it is more economical, so if you are prototyping over a molding or silicone rubber design, then go with this because of the development side. So one particular model which we have shown, which we recently published in one of the article, how do you process with respect to endourology session? We are going to tell you have a kidney, okay, of a patient, and you want to do CT image. You get a DICOM image from the CT. So once you get this, you need to have a 3D modeling software, because generally what happens is when you import the data, obviously there is no 100% data which is transferred. You need to be very careful and see if all the data from the DICOM image, okay, exact image you are able to read, yes. But when there is a transfer to the software, okay, there is a data loss. You need to make sure all that data which is present in the image is captured or not, or we tell it as a 3D reconstruction. Okay, wherever the missing data is there, we enhance that and make sure that it is patient specific, which is taken from the CT or the DICOM image, and then we convert it into .stl file and then 3D print. So just to give a comparison, the 3D printed model and the patient model, the 6-step process, how it helps in patient education. Okay, these days you need to educate the patient what exactly you are going to do. Whether it will help or not, that is the question. But you need to advise him that this is the problem, then you can do this. So different applications which we have discussed where you can use it. So improve patient understanding compared to your novel models. There is augmented reality also, 3D computer models you can use. So with the use of this, you can improve the patient's understanding. What is the procedure you are going to do and the plan for his surgical intervention. Surgical planning, how is it going to use in the clinical? So inspecting tangible patient specific models. Okay, you need to do a patient specific model with the particular patient data. So you can also go with the
Dr. Ritesh,
rehearsal of the procedure. If the
you have 2 more
procedure
minutes,
is
please.
complicated, yes. Okay, you can do the rehearsal. Training, okay, obviously you can do multiple process. You have the same replica of the patient, any part, anatomical part. So if any procedures you want to train your students, you can use it. And coming to surgical tools, maybe generally the limitations today is about the inferior of existing alternatives in function and suitability of sterilization. You can print a stent, okay, using 3D printing, and patient specific bioprinting. Okay, you can do the grafts. Okay, you can do the scaffolds. Okay, all maybe some tissues also, but these are at early stages of research. So important questions. Okay, obviously there needs to be a lot of collaboration between urologists and the healthcare professionals and the technology experts, wherein we can develop more and more technologies or get into 3D printing so that it helps us in patient understanding, surgical planning, and simulation turning. But the important questions we need to answer in our future research is, does this help in reducing the anxiety or improve recovery? Can the inspection or simulation of patient-specific models improve your surgical outcomes? So we need to do several studies to prove that this particular 3D printing is going to improvise more and more and help the patients in future. Few references. Thank you.
Thank you, Dr. Nitesh. We have already crossed time. We'll just take one quick question. Do you think that 3D printing will find place in a routine urologist, practice on a day-to-day basis?
We have printed few models, okay, of kidney or the bladder. Okay, we can print patient-specific models, and it becomes easy. Generally, for training purpose, okay, it's useful. But understanding the patient at the present level, okay, at least in India, I don't see that is important as of now, because you are going to confuse him more. Okay, but the technology or advancements and the understanding of the patients is also important with the time. So this particular technology, maybe it be 3D printing or enhanced, we are going with AR, VR, MR, all these technologies will surely help, okay, in different aspects when you plan to do patient-centric treatment.
Sure, thank you.
So what is the cost involved per model?
It depends on the model and
On an average,
type of
on an average,
material
on an average, what would the cost be?
Just a quick cost.
If you want to
for
print a kidney, okay, you get a spool, and if it is a ABS material, which you want to just replicate the model, maybe 250 rupees, 300.
Cost of printer,
Yeah.
average cost.
Printer cost is major. Okay, printing cost is one part. Printer cost is the second major one. Once you invest, okay, into
How much is it?
How much?
quick, say 50,000, 60,000.
Thank you.
Okay,
Thank you, Dr.
thank you, thank you.
That is an eye-opening talk for many. Thanks, Professor Nitesh Nayak. Now we move on to the next session, point counterpoint. This is a case of 2.5 centimeter renal stone. We have two participants in this session. I first call upon Dr. Soundarya to talk about RIRS for large stones. Is it the future? Over to you, madam.
At the outset, I would like to thank the chairpersons and the youth organization of USI for giving me this opportunity. I have no conflict of interest to disclose. How to move the slide?
Green. Send. There's a large green, but this side.
Sorry. So we all know that RIRS is an established standard of care for renal stones up to 2 centimeters. So for stones more than 2 centimeters, will RIRS become the future? This David is going to fight against that Goliath. The flow of the talk would be the guidelines, advantages and disadvantages of PCNL, RIRS, the limitations of RIRS and how do we overcome and what the future holds for us. We all know that the EAU and the AUA guidelines suggest strongly PCNL for stones more than 2 centimeter. Why? Because of the way high stone-free rate, around 78 to 95%, and the big disadvantage of our RARS being the multiple retreatments and longer retreatment time. However, the PCNL has significant complications associated. Despite the miniaturization, the risk of blood transfusion still remains, and it does not prevent against clinically significant bleeding despite miniaturization. And this is our own patient referred to us by from our native place, 2.5 centimeter upper pole stone, 18 French tract was used for this is what he landed up in, angioembolization. So, and there is evidence that there is a significant decrease in the functional volume in the particular region where the puncture is done. Evidence is there. And also high intrarenal pressures with miniaturization, more than 30 mmHg, longer than 50 seconds may contribute to postoperative fever. So also there has a steep learning curve which has been associated with puncturing the renal axis. So at this point of time, there is no doubt that RARS is definitely gaining popularity because of the advancements in technology. What are the advantages and whether it is efficient for a 2.5 centimeter stone? Let us see. So the stone-free rate from the published studies, it is evident that the stone-free rate is comparable and there is no significant difference between RARS and mini PCNL. And the review of literature says it is around 75 to 95% after the first or second treatment. The fluoroscopy time is, yes, definitely significantly lower than the mini per group. The hospital stay, the RCTs comparing mini PCNLs and RARS are in favor of RARS regarding the hospital stay and the initial cost treatment. And coming to the complications, there is no significant difference in the postoperative fever or sepsis rates between the RARS and mini PCNL. Coming to Steenstrasse, it can occur in 1.9% of patients from the published literature. So the major complications like ureteral avulsion and perforation are becoming extremely rare with the miniaturization of technology. And coming to the reoperation, the studies for 2 to 3 centimeter stones say that 83% single stage clearance, and most importantly, 78% it is ambulatory surgery. So this disadvantage is overcome by the fact that it is a daycare procedure and early return to work. This is a patient with large 2.5 centimeter pelvic stone. This patient came asking, I want only RARS. So this has non-dilated calyces and long infundibuli. We have used thulium fiber laser, initially fragmentation followed by popcorning. The case was done with a laser time of 35 minutes. This is a second patient with solitary kidney. So however good a PCNL surgeon you are, anybody has the fear of puncturing this single solitary functioning kidney. So this patient had a bifid system and we have used thulium fiber laser. It's not just the thulium fiber laser, but any high power laser could do the job in short period of time. The third case is an ectopic pelvic kidney. This kind of current generation flexible scopes with advanced flexibility and deflectability, we could basket the stone to the favorable calyx and the stone was powdered in no time. That is a laser time of around 30 to 40 minutes. So there are some true advantages. The patients come with a strong preference against PCNL because of the importance of lifestyle and employment factors. And there are certain specific reasons for choosing RARS in this particular subgroup because of some patients with severe cardiopulmonary comorbidities, solitary kidney, strict anticoagulation, or if the patient is morbidly obese like this, then we need these kind of gundas to make the positioning of the patient. And also if the patient possible failed percutaneous access, then RARS comes handy. However, there are a lot of limitations. I know Dr. Neerja will like to ask me, and I have the following answers. Longer operating time, yes, it is the technology has revolutionized. The Moses technology with the snow globe effect and the high power thulium fiber laser converts this large amount of dust in a large amount of stone into fine dust in a short period of time. Secondly, coming to ergonomics, yes, we have the current generation disposable scopes which weigh just around 300 grams, which is lightweight. And the robo-assisted flexible ureteroscopy can save you overcome against all these disadvantages like radiation exposure, wearing a heavy lead protector and all that. So if you don't have the robo, yes, we can do RARS in the sitting position like we do in our institute. So What about the stricture rates and preoperative stenting, multiple procedures? The answer is smaller flexible ureteroscopes. Most of them have the shaft French, diameter around 7.5 French, and very sleek. Coming to the sepsis rate, if there is good irrigation outflow monitored, the use of disposable scopes and the flexible vacuum assisted access sheath is the answer for all this. Currently, this is being popularized, and this flexible vacuum assisted access sheath can reach the calyces, it can cross beyond the UPJ, reduce the intrarenal pressure, and achieve complete stone-free status. So this published literature says that there is definitely higher SFR on the first postoperative day, lower indication incidence of infections, and a shorter operating time. So what about Steenstrasse or multiple stages and all that? We have these two important gadgets, that is with suction and the high power laser. And the stone, with this high power laser, the stone dust is formed in a short period of time. So this published literature on thulium fiber laser in this particular group of patients, that is 23 to 26 mm mean stone size, says that RIRS and PCNL, the stone free rates are comparable. So with this kind of digital optics and beautiful vision, 275-degree dual deflection, vision should not be a problem. Coming to the cost, though the initial treatment costs are lower when the RIRS group, ultimately with the multiple treatment sessions, it becomes equal and there is no significant difference. So what about the guidelines? It is time for a paradigm shift, and the indications for RIRS are going to expand. It is going to include large stones more than 2 centimeters in future. So the only constant thing is to change, and so it's time to embrace it, time for change. So with all these gadgets in hand, high power laser, new generation flexible scopes, smaller, highly deflectable laser fibers, and access sheath with suction, robotic FARS, RIRS, yes, it is going to be the future. And the day is not so far when a patient with this kind of staghorn stones will come to your clinic asking you, please doctor, don't puncture my kidney, I want only RIRS. So thank you and welcome to the future.
I now invite Dr. Neeraja Tillu to have a viewpoint on mini PCNL.
Good morning, respected seniors and my colleagues, and thank you to USI and you to give me this opportunity to present at the Youth Conclave. That was a brilliant talk by Dr. Soundarya. However, I would like to put forth the counter argument. So mini PCNL will stay for a large stone, which is 2.5 centimeters. Yeah. So let's go back to the basics, the history of mini PCNL. In 1998, mini PCNL was first described using the 15 French track. And over the years, the advances in instrumentation and fluid management have led to many miniaturized devices with sizes from 4.8 to 22 French, which is the super mini, the ultra mini, and the micro PCNL. So mini PCNL is mainly sheet sizes of 11 to 20 French. This is the paper from MPUH, which shows the sheets and the different instruments which are used in mini PCNL. Also the micro PCNL, the ultra mini PCNL, and the super mini PCNL. So the general advantages of a mini PCNL is that it is a versatile technique. It can be used in different patient positions using fluoroscopic or ultrasound guidance, and a tubeless or a totally tubeless is possible. It does not need laser necessarily. It can be done using less than 550 micrometer laser fiber or a miniaturized ultrasonic lithotripters or pneumatic lithotripters. The stone extraction is aided by the Bernoulli vacuum cleaner effect or the active suction, or can be done by baskets or graspers. So this is the first three images show that the fluid through the tip of the nephroscope creates a front of low pressure through which the fragments are extracted on the withdrawal of the scope through the Bernoulli's principle. So as Dr. Soundarya pointed out, the EAU guidelines and the EUA concur that PCNL is the first line of treatment. There is strong evidence for stones larger than 2 centimeter, and second line being flex URS or ESWL. They have not mentioned mini PCNL in the guidelines, but they have given evidence that stone free rates were comparable in miniaturized and standard PCNL procedures. And mini PCNL was associated with longer operative times, but the complication rates were comparable. So again, the more than 20 mm stones, the first line treatment is PCNL. So what is the current literature which compares mini PCNL to RIRS for 2 to 3 centimeter stones? There is no robust data. There are no RCTs. There is only a few prospective cases, of which the first study was done from China, in which 115 patients were there. The stone free rate was lesser in RIRS 71 as compared to 96. The operative time was longer in RIRS. Hospital stay was shorter, but it was PCNL was cost effective considering the retreatment rates. A similar study again done for a solitary kidney, which also showed that the stone free rate was lesser in RIRS. The operative time was longer. The hemoglobin level drop was comparable, and complications were not statistically different. Again, another study which showed how to diversify patients either into mini PCNL or into RIRS. There they noted that RIRS did achieve a lower stone free rate. It had more overall complications, more chances of urosepsis, and they said that lower calyx, multiple calysis or severe hydronephrosis was associated with a lower stone free rate. A recent study had similar findings. So mini PCNL, what we know is advantages in terms of stone free rate, in terms of operative time. The other factors which I will discuss further is ahead. Residual fragments is a problem. In most studies, the clinically insignificant residual fragments are between 2 to 5 mm. 80% pass within 1 month, but the rest can remain up to 3 months. So for better stone removal, fragmenting and extracting is preferable to dusting. And there was a study by Osgore who studied 384 patients, out of which 44 had CIRFs. 15 of them showed symptoms, regrowth after 2 years. And the study stressed the importance of treating CIRFs as former stones, and leaving RFs can cause infection, regrowth, and need for a second procedure. Another study by the EDGE group done on 232 patients also stated similarly that 29% of the patients required intervention. Both fragments more than 2 mm and 4 mm showed regrowth, and second group, which is more than 4 mm, was associated with more complications. So they are not as innocuous as we previously thought. So the lesser operative time has been proven in the mentioned studies, and with the advent of mini supine PCNL, operative time has reduced. It has also been shown in a study from Apollo Chennai, and there is a possibility of tubeless and totally tubeless, which also reduces the timing further. So the cost, as rightly pointed out, there is a cost to the patient. Not all can afford RIRS. Pre-stenting may not be required in all cases, but that is done routinely. Increased operative time, the cost of DJ removal, the cost of disposables, the cost of readmission if it is staged, the cost of emergency visits if there are any residual fragments. So mini PCNL can circumvent a lot of these costs, which is important to us in government setups and as private practitioners. Also to especially those who are freelancing and in a government setup, mini PCNL provides reusable equipment, durability is there with these techniques, and the cost with the purchase is lesser as opposed to the maintenance of the fragile ureteroscopes, which is done routinely by residents with an additional cost of disposables. Urosepsis is a factor. A small access sheath or no access sheath use is a risk factor for SIRS, and it causes due to raised intrapelvic pressure. So every renal injury begins after 60 minutes of raised intrarenal pressure, more than 15 mm Hg, and long operative time and increased irrigation rate more than 25 ml per minute are risk factors. So in opposed to that, vacuum effect is there in mini PCNL, which leads to lower renal pelvic pressures, and there are concerns even about increased pressure because of less outflow in mini PCNL. However, this has not been replicated clinically. So risk of Steinstrass is a problem with moderate size renal calculi up to 17%. So these lower retreatment rate, it is a better option in pediatric patients because of giving general anesthesia for each procedure. Also in solitary kidney, it is a better option in impacted upper ureteric stones, as proven by several meta-analysis. So the 1 month stone-free rates in URS was lower than that of mini PCNL. Lower pole calculi require a favorable anatomy, a good infundibular pelvic angle, infundibular width, height, and pelvic axial height. So in spite of this, it shows 60 to 93% stone-free rate. Mini PCNL does not require this and shows a good stone-free rate of 90 to 97%. So for those who are trained in Maxi PCNL, the transition to a mini PCNL is the right direction for 1 to 2.5 centimeter stone. There is a better surgeon comfort with mini PCNL. Yes, there is a risk of hemorrhage. It is the disadvantage of mini PCNL as compared to RIRS. But if you compare it to the rest of PCNL, there have been studies which have shown minimal transfusion rates and much lesser risk of hemorrhage. The length of stay is not a valid point for comparison in Indian population. The cost of hospitalization in most centers is lesser than Western population. The length also depends on the patient preference in India. There also in mini PCNL, there has been a concept of ambulatory surgery. The patients eligible were less than 80 years, ASA less than 2. RIRS, as pointed, is not as innocuous. There is a 10%, there is a complication rate, and of course, the famous study by Professor Traxter. There have also been a close study which have shown that more than 20 mm, the complication rate, the retreatment and the rehospitalization rates were significantly higher. So the future of mini PCNL is bright. The incorporation of active suction is the most intriguing development of mini PCNL, which in combination with laser lithotripsy offers potential for complete stone clearance. There are robot assisted suction devices, and it is the ultimate precision guided surgical tool. So computer guidance for targeted percutaneous access is the goal. This is the study from MPUH which shows the suction device. And to conclude, mini PCNL is the procedure of choice, and it remains the superior for renal calculi. It is also, bleeding is more in mini PCNL, the length of stay is lesser. And with precision surgery and miniaturization of instruments, PCNL is the future.
Thank you, Dr. Soundarya and Dr. Neeraja. Both of you put our efforts. There is no counterpoint here, counterpoint here. Audience opinion, as of today, if you have 2.5 centimeter stone, which is suitable for both. Think it is solitary stone in the kidney, pelvis. So how many of you will go for PCNL mini perc? How many of you PCNL you raise hand? Raise only one hand. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 10 or 11 are there for this thing. Please don't raise for the same. How many for the RIRS? Only one hand. No. 1, 2, 3, 4, 5, 6, 7, 8, 9. So 10. So it's as of now 11 score for the PCNL and 10 for the RIRS. So that is a good debate topic chosen by the organizing team. So that means it's 10-11. Hardly audience are 30. 10-11 is the score. So congratulate both speakers. Thank you.
So can we have comments from Dr. Said, please?
Congratulations, both ladies. To the point, and I was always saying that Flexible ureteroscope or retrograde intrarenal surgery is not to replace anything, is to take the place. And we have to think about personalized treatment for every patient. I believe that PCNL will stay there. The retrograde intrarenal is taking the lead, but we are not yet to fight here. It's just a cooperation between two systems. Doctors are very excellent to do the penny-perc, and some doctors are excellent to do retrograde intrarenal surgeries. The winner should be the patient, not the surgeon. Thank you very much.
So there's an interesting note. Dr. Saundarya's first slide was about David and Goliath. Now the question is David actually an underdog? He's fighting a giant, probably having acromegaly, who cannot see. David has a catapult. He can fire from a distance of few feet. And Goliath is moving with an armor which is tons of weight. So who actually is an underdog here? Is it David actually? So RIRS is not an underdog. I leave you with that.
One thing that is happening is, 3 years ago, we were debating for RIRS for 2 centimeter stone. This year, we're debating for 2.5 centimeter stone.
Absolutely.
Maybe 3 years on for 3 centimeter.
Now we are talking about medium burden stone. Huh? We are not talking about staghorn. Yeah.
Future, the volume also will come into picture.
Abhishek, one comment, like Dr. Saad been told, all the data which is supporting either of these procedures are coming from experts in that particular procedure. So it will be a skewed data. So I think ultimately what he said, that final point is the patient is what that matters. If in your hands RIRS for 2 centimeter, 2.5 is good, continue doing that. So ultimately it's the expertise of the person on that particular kind of procedure.
Absolutely. So thank you very much, Chandramohan sir. Thank you, Dr. Tanuj. And let us take this opportunity to thank Dr. Syed, who's flown down all the way from Middle East, spent 2 days, attended all the lectures. So with that, we move on, and we have the Europreneurs conclave or the session coming up next. But before we go on to that particular session, I call upon Dr. Lalit Shah sir to deliberate upon the need to protect urology and urologists.
Hello, good morning, everyone. Since last 2 days, we are hearing lots and lots of intricacies of urology. But first, now I'll be trying to go into a different direction, and so that there is a need to save urology and urologists. It's entirely a different perspective that we would be talking. And whenever I say you, I mean we, and I'm very much included. So please don't take any offense if I say something like that. Well, I hope that these days don't come. They never come, but probably these are the future likely to happen. Hopefully not in our lifetime. So why do we need the protection for urology and urologists? See, whenever we are talking about this protection for urology or the urologist, probably the people of my generation do not have much of a problem, or the senior people. But it is the youngsters, because every year 300, 400 urologists are coming. And it is the youngsters who are going to have lots and lots of problem if the specialty is not protected properly. So what are the needs for? It is a medical legal protection, professional protection, physical protection, mental protection, and financial protection. Medical legal safety, rapidly increasing medical negligence cases after CPA, and huge amount of compensation are there in one of the cases. And now with the change of CPA 19, from 86, the 19 has changed, and this is a tremendously toxic thing. It is more consumer friendly, and it is worse for the doctors in the hospital. The pecuniary limit has been raised from 20 lakhs to 50 lakhs, 1 crore to 2 crores, and from more than 1 crore to more than 2 crores in district, state, and national commission. So probably even the compensation will be higher. Another thing is the territorial limit. Previously, you can file the case where the doctor is residing or practicing. Now the patient can file a case against you at his place of residence. So you have one more trouble to hire a lawyer at that place, go there and sort it out. This is another problem with this. Another thing is the security deposit. Initially, if you lose a case in the district forum and you have to go for the appeal for the higher forum, you had to deposit only 25,000. Now you have to deposit 50% of this. So if you have been fined as 20 lakhs, so you will have to deposit 10 lakhs to go for the appeal. Like we know, see, this is a medical legal situation. So either the people should be from the medicine side and the judiciary side, so as to give you a proper judgment and all that. But doctors were hardly any members in the forum. But at least the president was always from the judiciary background. Now that has been done away with it. So it is most likely that there would be no person from judiciary, no person from medicine, and they would be deciding about you. Appointment of the member was by the judiciary committee, and now it will be done by the government. And you know how the governments are going to do a lot of politics, and all those things would be coming along. And then was a now there's a limit for the appeals. Now you would be able, initially you could go and appeal from district to state, state to national, national to Supreme Court and all that. Now this has been limited. Unless until there is a question of law, you would not be allowed more than 2 appeals. See, in the Calcutta, this one case, everybody knows now, by now, everybody knows that it was a huge compensation, largest compensation against this. And in Apollo Hospital also, more than 1 crore for wrong delivery of the child. These two were the cases where there was the issue of the doses of the pharmacological drugs. In the first case, it was the dose of the corticosteroid, which was beyond the limit, whatever has been prescribed in the textbook. And in this Apollo Hospital one, the oxytocin was given for more than whatever is described for the time being. Number of hours that it should be trial should be given. So what is important is that we need to go back to our basic books, because on paper we should be right. And most of the time we do not know about that. Whatever is mentioned in the book and what we practice is entirely different. Like this is a very simple thing. We all know that post-procedural renal bleeding, sometimes beyond all those things, ultimately life-saving thing is a nephrectomy. But if you go through the Campbell, you would realize that this is not mentioned at all. They always talk about angioembolization, angioembolization, and angioembolization, which may not be practically possible in all the scenario at various places in India. But when the matter will go to the court, they would say nephrectomy is not at all mentioned. You have done the nephrectomy. So you would be in trouble if the lawyer is very bad on the other side. Similar silver nitrate, nowadays, anyway, nobody uses, but we were using it for the internal things for chyluria, and in the bottle it is mentioned for external use only. So even the death has occurred because of something else, they would blame this and you would be held negligent. Like nitrofurantoin. For female prophylactic antibiotic, the antiseptic, this is being used for like this. Many patients don't come back and taking to go on this. Till I came to know about this, lot of patients were taking it since more than 5 years. And then I realized the literature does not support for more than 1 year continuous use. So if the patient gets some other problem, then it will be blamed on this. Similarly, Jofer, everybody is using for PONV, that is the preoperative and postoperative nausea and vomiting, but it is not approved for that. It is approved for nausea and vomiting after chemotherapy only. Similarly, pre-procedural urine culture, whether it is a PCNL or RIRS or urethroplasty. Urethroplasty, we know that it has a procedural inherent failure rate of 15%. So if your case fails, because we all know what we do not do this. Patients are coming from distance, we give broad spectrum antibiotics, send the culture and do the procedure after 48 hours. And then if required, we change according to the culture. 99% of urologists are doing that. I'm very much included in that. But if the patient fails and the lawyer is bad, then he would say because the doctor in his haste to go ahead to earn money and do the surgery has subjected this to the failure. And it is because there was no pre-procedural sterile urine culture. So what we need to do is learn about the things little bit, because there are not so many things that we practice on a regular basis. So we can change our practice and we can create Indian literature because the literatures are not there. If a good Indian literature is there, which says that, okay, in life-saving situation, nephrectomy can be done or should be done, or that is what is there. If it is in a small place where other facilities are not available, this would be life-saving. So that would help in case of any problem. Now, most important thing for the youngsters is the professional safety. Urology is being poached and encroached left, right, and center by the non-urologists. Pediatric urology now, since our time, 40 years ago, when I passed out, and when the new persons are coming, I am realizing more than 80 to 90% of pediatric urology has been taken over by the pediatric surgeons. Andrology, infertility part, I'm a modest man, so I'm writing 80 to 90%, it is almost 100%. It's taken over by the IVF centers. Uro-oncology, more than 50% has already gone to the surgical oncologist. Uro-endoscopy, lesser we talk, better it is. Every Tom, Dick and Harry is doing the uro-endology. A female urology, more than 40-50% is being done by the gynecologist. So what is happening at when we passed out about 40 years ago, there was sufficient piece of cake readily available on our plate. So if somebody is taking from nearby, that didn't matter too much. Now the youngsters who is coming out is hardly having anything in the plate. With difficulty, he is able to keep a small piece of bread, forget about the cake. And that too is being snatched by somebody else, and you have to protect yourself and your plate and your bread. And now these aggregators, various aggregators, they are creating more and more problems. Short training programs. So many are doing the TURPs and PCNL, 7 days, 5 days courses, sort of things were going on. So USI passed a resolution in 2019 that no urologist would train non-urologists for urological procedure. Fortunately enough, this has worked to a certain extent, but more needs to be done on a larger scale. Other aspect is non-urologists are claiming themselves to be consultant urologists on their letterhead and signboards and all that. Local people, because of their own personal problems, are not able to complain against them. So I believe that the USI or the zonal USI should always complain against them to the medical councils. Because the youngsters would be facing unhealthy competition from the semi-qualified quacks. I call them the semi-qualified quacks. And even the patient would be getting the worst treatment. All the section of society, media, politicians, bureaucrats, judiciary, police, etc., are against the qualified allopathic doctors. They do not have too much problem against the quacks. So when we say that, who can change this? It has to be done by the unity is the strength. This is very common. Everybody says, everybody knows about it. But what about this? Unity will come only when there is membership. If you would see a good number of our urologists who are qualified enough and practicing since 3 years, 5 years, 10 years are not USI members. So everybody wants to go to heaven, but nobody wants to die to get there. भाई ऊपर जाना है, स्वर्ग चाहिए तो मरना तो पड़ेगा, लेकिन मरेगा कौन? Everybody thinks कि भाई USI हमारे बदले मरेगा. But after all, USI, what is USI? You are USI, I am USI, everybody else is USI. So you have to die. So you have to work on these things rather than thinking and expecting that only USI would do everything for you. See, Indian Medical Council regulation says very clearly, membership in medical society for advancement of profession, physician should affiliate with association and society of allopathic medical profession and involved actively in the working of such bodies. So this is in an interpretation, it is a legal duty that you have to do this. If you are not doing, it is an unethical practice. Similarly, exposure of unethical conduct of the friends and colleagues should be exposed by you. But anyway, who will bail the cat? Hardly anybody is doing that. So another thing is that I personally feel that it is high time. Academics is very important. Whatever we are today is only because of academics. Academics was there, it is there, it will always remain there. But I think that it is high time that the USI should move towards society beyond academics also. So to look forward, the welfare of the members, safety of the members should be there. Because as of now, as I understand, almost 95 to 98% of time, energy, and money of USI is being spent on the academics. But there are other duties also which should be taken care of, whether it is the safety of the members, the job opportunities for the members, the medical legal safety for the members, the problem with the industry is there, the financial things, medical legal things, so many other aspects are there which are non-academic urologically, that should be taken care also. But who will do that? How will it change? If it is since last 50 years, it is not like this, it is not going to change. It is you who have to make the difference by a consistent efforts. In one day, it is not going to change. It will take time. It will take time, but then it can be done, it can be brought out, and it will be only for your future. Another thing is physical safety and the mental safety. I would not go into that detail. So what is important is be an active member of society, be proactive, and spend some time on thinking and executing ways and means to protect urology. Thank you. Thank you very much.
Thank you, sir, on a wonderful deliberation. Indeed, it is time to think laterally. And on that note, we start our next session, which we call as the Europreneurs Conclave. To moderate this session along with me, I call upon Dr. Raman Tanwar if he's here. He'll be joining us shortly. I also call upon D. Ramesh sir onto the dais. Dr. Krishnamohan sir, please come onto the dais. And Dr. Rajiv TP sir. He'll also join us. So getting started, I was a urologist who passed out, and I went for my fellowship training, and I was very happy to complete my fellowship, but I was at total loss what I would do after this. I applied for 2 government jobs. I thought that will be the safer career for me. And unfortunately, when I completed my fellowship and went back to Bombay, none of the 3 big medical colleges were willing to take me. So I chose this bunch of a group of smart individuals who I thought would help me do some kind of a private practice. And therefore, I set up a set of questions that I posed to these 10 odd gentlemen and was looking for a reply from them. I have nothing to disclose. So that's what I did from 2007 to 2015. I learned, I attended workshops, I was training, I gave exams, I did some coaching for it. Eventually, I also taught. So I thought I did everything that was required to earn reasonable amount of bread for my family. And after, I also did a bit of academics, got some publications, but then real life scenarios started haunting me. So I started looking at my colleague, my schoolmate, who was a wonderful professional. He became an entrepreneur. He had 5 marriage halls. The another one had 5 restaurants. And I asked him, how did you become an entrepreneur? He said, entrepreneur is basically a person who starts making money or running business by taking a lot of financial risks. I had zero know-how of how to set up a business because I was never taught one. Therefore, again, I came to these gentlemen. I decided that with the aid and help of these gentlemen, I would become what I thought is a Europreneur. That is, I would start my own enterprise. I would take a financial risk, but how much? I thought this is a startup, like the startup was a fashion. Every IT guy was doing a startup. Yes, I thought, yes, my hospital, the new hospital will be a startup. I have an idea. I went to the drawing board, started drawing a few things. After a while, I realized there was not one question that needed to be answered, but there were a bunch of them. So is it a beneficial venture? Eventually, will I be able to earn enough to feed my family? Where should I set up my hospital? I am from Nagpur. I trained in Bombay. I did my fellowship from Nadiad, and I have no idea where to settle. Do I have the capital? Of course I don't. Do I need a loan? How much do I invest on instruments? And now, does this investment actually become viable? What clearances do I need? That time I had Dr. Jaspreet, who was my co-fellow. Should I start practice with him or go back to somebody in Bombay whom I was working with? I did not know. Do I require a loan? Do I require insurance? I had absolutely no clue where I was headed for. Therefore, this conclave, my friends. So let's get started. To answer my first question, I call upon Dr. Rohit Joshi. And sir, I ask you that today I am 8 years in my practice, not being able to start my own hospital actually, but how much do I deserve? Abhi, after 8 years, if not now, when? Good morning, friends. Our chairpersons, a very warm welcome again to Hyderabad, and a very thought about, very good concept which Abhi has brought. And Abhi, when he asked me this question, before I go to answer his question, let's take this opportunity to acknowledge the efforts put in by the whole USI and the U Council, especially Z, Karthi, Abhi, every one of you have done a great job. How much do I deserve? So I asked him, Abhi kya chahiye? Abhi asked me, Rohit sir, aapko kya chahiye? So I thought I don't need to spend 10 odd minutes in answering this. I'll just have 20 seconds to answer your question. Abhi.
Video, please.
क्या चाहिए बे तेरे को?
दुनिया.
It's a very simple answer. There is no limit to your dreams and there is no limit to your expectations when you talk about money. But first of all, let me have a very clear-cut disclaimer that this session is all about being Europreneur. And as doctors, we have been falling under the purview of CPA, but mind well, we are into business. We are not into charitable organizations. So it's not shameful. It's not embarrassing to talk about money. So ultimately, at the end of the day, what counts is money, not how many publications we had, not how many presentations we had, not how many AUAs and EAUs we have attended. Ultimately, at the end of the day, your family needs money. So this is the quote which I would like to sound a little bit harsh, but yeah, it's an important aspect. Let's not forget that. Yeah. So, Abhi, how much do I deserve? But before answering that, let us define the I. How much I deserve? Now, who is this I? Now, this is me, the small one. This is my father. When I was resident in urology at my 33, 32 years, till that time, my father was feeding me. And lately, my wife took that job over. Then I started my wandering practice. I was going 100 kilometers, 150 kilometers, there, that, taking all these things in my car, become a wandering urologist. Accumulate a little bit of money. Then I set up my own nursing home, which was a 10 bed. And that was having a 10 by 10 feet consultation chamber. And then I went placed order of my 100-watt laser. The luminous guy came and sat in my chamber. Sir, are you serious? And I didn't have even lift to accommodate that luminous laser machine. So we had to assemble everything, disassemble, and then get the machine up in my nursing home. So that's how you grow. And then ultimately you have, 2-3 hospitals under your name, and then you become this. So it's a journey. So everywhere there is a cost. So before we answer how much do I deserve, let's identify how much cost we have put in making of I. We all know Bahubali made 1,200 crores, but we need to know that a lot of efforts were put in making the Bahubali. So first thing is everybody are here academicians. So let's not talk about the cost because everyone is on merit. Raju, please come on, Dias. Main things are costs incurred towards procuring urology equipments and setting up your own establishment. Now, there are 3 different kind of costs involved in making of I: capital cost, recurrent cost, and the recycling cost. So first, let us take the capital cost. I'm sure Anish is going to take it forward. These are the basic equipments and the high-end equipments, depending on which stage of I you are, whether you are in wandering, whether you are nursing home, whether you are entrepreneur. Depending on that I stage, you need to procure all these equipments. Factors to consider: how much you need to invest, locality of setup, class of your clientage, your core specialty, whether you are in solo, group, whether you are in teaching institute, corporate, and whether you are empaneled with Yojana. So my subsequent speaker are going to take care of this. I'm not
going to in details of that. But thing is, most important factor is who and what is your father, or still better, your father-in-law. If he happens to be my father or my father-in-law, I'll have an AINU in Mumbai. That's Antalya Institute of Nephrology. So forget about it, all this. Anyways, so next comes is recurrent cost. Now the recurrent cost can be planned and it can be unplanned. So whenever you're setting up your things, you need to take care of each and everything. These are all the planned costs. Subsequent speakers will talk about that. And there are unplanned costs, like there is a breakdown, malfunction, there is theft, burglary. So you have to make provision for each and everything. So your income doesn't has to just satisfy your, day-to-day maintenance. It has to take care of the unplanned things also. And there is a recycling cost. Somebody posted in a group that, he ETO'd his flexible scope and it got damaged. So these are the things which you need to take care. Sterilization costs and upgradation costs. For example, if you today buy a laser, that's a 20-volt laser, time and again you will have to buy 50, then you have to go 100, then you have to go 120, 180, Tulmium fiber, this company guys ultimately will own your money, will do their R&D and produce new and new machines for you to buy every 3 year or 4 yearly. So don't fall into that trap. So cumulative cost incurred in making of eye, if for a wandering urologist maybe 25 to 50 lakhs, for a nursing home urologist maybe 0.5 to 1 crore. And for this, you need 1.2 crore. This only about urology, nothing else. So if you trade off, like see, if you're roughly, let's say 1 crore is your initial investment and there is 11% lending rate and you want to lease it for 3 years because at 3 years you need to debt free. Then only you can invest and then you can, grow your money. So the per EMI, like per lakh EMI is 3,274. So for 1 crore, you will be paying 3,27,400 per month. Now then there is recurrent cost, AMC, CMC and everything put together, that will come around somewhere between 23,333. So put together for setting up your thing with 1 crore loan, you need 3,50,000 per month. So after you set up your thing, if you don't do any surgery, if you don't look at one OPD, you will spend 3,50,000 rupees from the first month. And then you need to do cases. So this I've done a lot of micro cost analysis in each and every procedure. And this is, I'm not going to detail the breakup, but this is the nutshell. For a whole up, your recurrent cost might be 3,000. For RRS, maybe 20,000. URS, maybe 4,000. Mini perk, you can have 4,000. Now let's say you start doing 20 cases in a month. Each one 5. You may grow to 200. God bless you, but this is the initial part. So for whole 5 cases will fetch you 15,000. 1 lakh for RRS, 20,000 for URS, 20,000 for mini perk. Ultimately, to do those 20 cases, your recurrence cost will be 1,55,000. So setting up per month EMI is 350, and for 20 cases you will spend 150. So roughly, you will be spending 5,05,000 rupees to do those 20 cases. So there is a simple equation. You need to charge 25,000 for those 20 cases. That will sustain I, only the I. But before I figured it out, he struck, and he struck badly. And there was a surgical strike on all the doctors. And then this happened.
अरे मृत्यु के बाद क्या होने वाला है कौन जाता है जो मौज करनी है अभी कर लो जो खाना है खा लो घी पीना है पी लो आनंद से जी लो
So this Mitro hurt is bad. So now he wants us that maximum Rohit you can charge is 10,000 rupees a case. Now we need to earn somehow 5 lakh rupees to sustain the eye. So now I need to do 50 cases. That was also okay. So I figured it out that yeah, I'll need 50 cases, 10,000, 5 lakh rupees, I'll be happy. But then I realized that at 35 years, I am no longer an I. I have become now we. I have a beautiful wife and she is quite high on maintenance. And not to forget, she was the one who fed me when I was doing my residency. So now I have to support her. So they are all having that. So I figured it out, chalo, let us do something, let's sustain we. But by the time I become, nursing home and ventured into entrepreneurial urology, I thought, gosh, we is no longer a we. Now we have become us. Now 3 idiots with me. These are 3 small kids, they are with me and they are having endless of kind of demands for which we need to earn a little bit more. So to sustain, raise and maintain and grow this I, we and us,
Now you tell me how many cases you need to do with a ceiling of 10,000 per case. I think we all will meet again in European season 2 in 2023, and that time I'll give you the answers, correct answer for those things. But before I conclude, let's see this thing. It's not just about the money, it's all about the time, Karti. It's a time and money, you have to balance this thing together, and ultimately it's your health. Because even if you're sleeping on a bed of 1 lakh or $1 million, you need to be happy. So you need to figure out a balance in your life, and you need to spend time in doing what you love to do. So friends, play, engage in sports, dance, you can sing, conduct, anchor the events, and do whatsoever that can make you happy, because it's not just the money that brings happiness to you. So have a balance in your life. And lastly, this will be a very crisp take-home message. There is a very thin line between need and a want. So never chase wants in your life. Always pursue what you need in your life. And secondly, there is even a thinner line between being wealthy and being rich. We know Ratan Tata is wealthy and our Ambanis are rich. So you choose your icon, you choose your role model, whom you need to follow. Thank you so much for patient listening, friends.
Thank you very much, Rohit sir. There are two sides of this coin. I invite one comment on each. First, I'd ask Ramesh sir to make a comment on the fact that how much do I deserve? Is this shout from a youngster who's just passed out, from a professor who's earning 2.5 lakh rupees a month, and he's been doing that all his life. And now I come out and within 2 years, I say I deserve 5 lakhs. How fair is this?
Rohit is a very eloquent speaker. Wherever he goes on stage, he keeps the audience engrossed. I can tell you from personal experience, when we joined MBBS, this was in the 70s, and where I am today, I never even dreamt that I will reach this space. So I have to thank my parents and God for letting me where I am today. So all of you who have passed about 5-10 years ago, recall your MBBS days. Did you ever imagine that you would be what you are today? So by and large, majority of us, almost 100% of us, have achieved much more than what we dreamt of when we joined medical school. So the level that all of you want to achieve is different. Some wants to become wealthy, some wants to become rich, but you look at where you started your dreams with. I believe that there is space for everybody, but the level has to find the water has to find its own level. So Rohit cannot set a standard for all of you. I cannot set a standard for all of you. All of you have to find your own level. What Abhishek told about me about a professor earning 2.5 lakhs is not really true, because I work in a setup where I have the luxury of both a corporate style setup and a medical college setup. So I get a salary as a professor. I also get my own professional fee during the working hours. So I've got the luxury of going back home at 5 o'clock with the sufficient package to take care of us. But everybody does not have to have the same example. The water has to find its own level. So I would leave it for the young urologist to determine what is it that you want to reach. But as long as you practice ethical practice, I'm sure there is space for all of you in the society today. India is a large country and there is sufficient space for all of us.
So one comment I invite from Rajiv sir. Sir, if I publicly say that yes, I want to earn and I want to earn a lot, as a senior urologist, do you see this to be objectionable, or is it against our cultural values?
See, I can say you're the master of you. Your level or thing should be fixed by you. You know what is your level of satisfaction. I will know what is my level of satisfaction. And it varies from individual to individual. As Ramesh sir said, when we joined, we didn't have any ambition, and God's help, we have reached this level. So compared to Ramesh sir, I have the privilege, being in government setup, I can do practice. So we get a monthly salary. Apart from that, with limited practice, we can have added thing. So the thing is that when you have the initial thing, you know what you're going to get and you fix up your thing within that limit. So the thing is that ambition goes by, as Rohit said, I have set up. There are many people starting a small setup. He's happy with it. It is within his hands. But if your ambition goes, you want to a bigger setup, then your tension also increases day by day because the daily maintenance, monthly maintenance goes significantly high. So my thing is that whether you do practice, everything should be in your hand. And one message is you should keep sufficient free time to your better half. Finish off everything by 7, be at home by 7:30 and enjoy the life. If you spend the day till 11, you'll have more tension, you will get all the comorbid diseases and you're bringing down your lifespan. Enjoy your life till whatever level, have sufficient free time.
Thank you, sir. After this, I went to Dr. Aditya because I thought setting up a hospital was what I was looking for. And I wanted his opinion, whether it is going to be beneficial or not. And then subsequently, we'll have comments on this from Dr. Krishnamohan, sir. Over to you, Dr. Aditya.
Thank you, sir. Good morning, my seniors and my colleagues. First of all, I would like to thank the Youth USI for giving me this opportunity. Rohit sir's talk was excellent. I enjoyed it a lot. Now let's see my topic, setting up our own hospital, the benefits and pitfalls. This is quite an interesting topic actually, because each and every one of us is either going to have this thought, had this thought, irrespective of whether we are owning the hospital or we plan to own one. Now, before starting, I'd like to put up this disclaimer. Nothing is wrong or right. It is all about our perception. The following slides is how I perceive. My advantage might be someone else's disadvantage and vice versa. So this is how we'll go. We'll first see the pitfalls, the benefits, then there are surveys, international and national. So starting with the pitfalls, let us see the pitfalls through the eyes of two doctors, brilliant doctors, best friends, Dr. A and Dr. B. Both of them have recently passed out. Both of them are brilliant surgeons, same skill set, financial status, everything. Dr. A wants to start his own hospital, whereas Dr. B wants to join a corporate or a trust hospital. Let's see the pitfalls through the eyes of Dr. A. So at the start, it is very important to answer this question, that whether we want to do a group practice or a solo practice. Where do we want to establish our hospital? Is it 1-tier city, 2-tier, what? What is the population that we are going to serve? What are the endemic urological problems? What is the number of urologists already practicing there? So there's a lot of thinking and research. Finance, obviously, Rohit sir has said that excellently. And through a survey that was done, the minimum amount that is required by a urologist is around 75 lakhs for the most basic office practice. Then there are laws, NABH accreditation, the Ayushman schemes and everything, which we are not aware as at a resident level. We need to learn these things. Now, this is one point that most of us are very apprehensive about, management and stuff. It works both ways. It might be a benefit for you or might be a pitfall. So there's staff selection, there's staff training. I'll give you an example. While doing PCNL during my residency or when I was working in a trust hospital, the only thing I was worried about was puncture, my skills taking the stone out. But when I started my own practice, that was the least of my concern. My first concern was whether the CM guy was showing me the kidney or not. So this is just a very small example. Similarly, instruments, when we work in already established hospital, we don't care whether it's a Wolf instrument, it's a Stores instrument, as long as the vision is nice. But once you have to buy it, you see everything. What is the price? What is the after sale service? How long will it last? And obviously the headache that comes along with it. So, and then there are these advertisements and competing with older hospitals who are already established. As a medical student, exposure to social media and everything is a little bit less. However, all of us are trying to improve in that. And then, of course, there are these taxes, GSTs and others. This financial status, we are nil. So these were the thoughts of Dr. A. Now, I'm not saying that Dr. B does not have to think anything, but he has to think less about it. So most of the things are already taken care of. So once Dr. A hospital has started, he's now running his practice. Now, what are the problems? There's always this uncertainty, whether the patients are going to come. You have already taken a loan, whether you will be able to pay the EMIs and everything. Also, you have to deal with initial less patients, so the confidence might be less. And God forbid, if you have any complications, then there is no end to it. Work-life balance. Now, again, this is both a benefit and a pitfall. So as a pitfall, what I'll say is, it is difficult, as in you're not the boss. There's always a boss above you, not in a private, but in a corporate setup. Then there will be recurring staff issues. One day, one sister is not coming and stuff like that. Wear and tear of instruments, financial issues, near competition expansion. Much of this will be taken care of in the subsequent lectures. And then throughout career, this ever-changing laws. I'll give you an example. In Gujarat, in the last 2 years, it's always, every time you wake up, there might be something, they've come up with a new problem. Now, this was a building use certificate, which they came up that those hospitals who didn't have the BU certificate, they had to either obtain one or have to close. Now, most of the hospitals were already 20 to 30 years old. At that time, Ahmedabad was not even a city and the periphery was not even a taluka. So it all used to be Gram Panchayat has given the permission and everything was like that. Overnight, 400 Ahmedabad hospitals faced closure and mine was one of them. So something comes up and the government directly blames the doctors. So there was this again, a very, in a big multi-specialty hospital in Ahmedabad, a fire broke out, multiple patients died. Overnight, the fire laws changed, that you have to put this, you have to put that. Once we were done with that, now again, they came up with something that ICUs should be on the ground floor. Because of this, we recently had a strike 1 week back. So there's always this uncertainty. You never know what is coming next from the government. And patient-related issues, let's not talk about it or this will never end. And then permanent commitment. If you are getting a good opportunity somewhere else, it is very difficult to let go of your hospital and shift to a new place. So why would Dr. A even consider of thinking his own hospital? So the answer is full control. You are the boss, man. You decide who you work with. You hire people who have your thinking. You free people who do not match with your thinking. This is slightly difficult in a corporate or a trust hospital because most often you have to work with people we don't get along with, and that creates issues. And control how you work. So I am doing prone PCNL. One fine day, I think that's let's start supine PCNL. I started, nothing to think about. And same goes with instruments. I'm doing PCNL, I want RIRS, I'll buy it. So I do not have to explain it to any manager or to an admin who has zero medical knowledge, and I do not need to take his permission for that. So there's this freedom. So we don't need to jump through hoops of approval for this. A work-life balance. So this is interesting because you do not need to take permission from anyone. You want to go to a vacation, you do that. If some month this patient flow is slow, what you will do is you can extend your hours and do that. So it gives you a lot of flexibility, which trust and other hospitals won't do. Okay, so we can have life outside work and there's always this. And there's also greater job security. No one is going to fire you from your own hospital. Now, very lucrative, yes. So what I feel is owning a private setup is like equity. There are risks, but the benefits are greater. And working in a corporate or a government or something is like mutual fund. You're safer, risks and benefits both are slightly less. So then better patient relationships. Patient comes to you, he has something good to offer. You choose his advice and you can implement it. This won't be possible if you're working somewhere else. And there's higher patient retention rates. So via this, let me give you an example. If you are going to a hairdresser, who would you like to go? Would you like to go in a multi-specialty or there are a lot of hairdressers and you never know which one is going to cut your hair? or it is owned by a single individual and you know that that guy is good and he's going to cut it. Eventually, at the end of the day, you might want to sell your hospital to a larger group or a hospital system, or you can negotiate and negotiate a position at your practice, or you can bring on a younger partner which you can mentor and you enjoy life. Now let's go to some surveys. So international surveys were done, and ultimately all had the same agenda, that whether individual private practitioners are more happy. And they found out that the satisfaction rates were slightly higher. And I would like to quote this: decisions are made strictly for the best of the patient without having to try to make the employer happy as well. See, doctors in general are quite sharp, so we do not want anyone else controlling us. And this was a Desi survey which I did. So there were total 109 urologists participated, out of which 34 were working in a private setup and 75, let's say it to be others. So the financial requirement was 50% of them said that they had greater than 1.5 CR required for that. Income was okay. There was no difference between the years of practicing and the income. Now, type of urology, this is something important. No private practitioner was able to do total subspecialty, but however, 5% of the others were able to practice only that subspecialty of choice. And this, now, how much time do you devote to your family per day? So in this, the private practitioners, greater than 3 hours, 50% of the private practitioners were able to do so, whereas 40% from the other group. Satisfaction index, this is also very interesting, that private practitioners, 30% were very happy and 20% of the others were very happy. For their family time, both of them were good. However, the satisfaction index, now the private were 30% overall very satisfied, and the others were 38%. Now, for this, I'll tell you, at the start, I said, it all depends on your mentality. I guess private practitioners are more risk takers and they want everything. Apan ko sab chahiye, Rohit sir told. And this last was this: if given an option, would you like to change your type of practice? Only half of the private practitioners wanted to change their type of practice, whereas 2/3 wanted to do that in others. So I would like to end only with this thing, that to know thyself is the beginning of wisdom. There's no wrong or right. Okay, you need to know what you want from life, and then everything has its own benefits and pitfalls. Thank you. Thank you so much.
Thank you very much, Aditya. I request Dr. Krishna Mohan sir to share his own experience at Mira. So we are not asking you what anybody should do. It is your own individual experience that will.
Yeah. Thank you for the opportunity. First of all, to start a hospital is not a big thing. We should first understand. The thing is that once we have a training program, all the people, postgraduates under some seniors, after that completion, they will be working under some seniors. So while doing and learning the surgeries and having a rapport with the patient, at the same time, have a rapport with all the people in the hospital, including the sweepers, securities, admins, everybody. So that the thing is that you know how the thing happens, first of all. For example, most of the people will be using the scopes. They do not know how it is purchased. Stent they are using, how they purchase, they do not know. So there are opportunities to utilize that while you are working the PG or doing under somebody, working under somebody, utilize how all these things are going on. So the first step is over. The benefit of working in a private setup or own setup is that you can project yourself at any level, but in corporate, it is not possible. Income also is not possible. There is a capping for the youngsters also. The third thing is that while you are doing a setup for the hospital, what I did is that you can have a hurdle of starting a hospital, the licensing, processing, the first investment for the things. So if you have the capacity and good rapport with a well-running hospital, which is not having that department, you can take over that space initially, so that the benefit is that you don't have to struggle for the licensing. Lot of procedures are there. You can avoid that. You can invest, and whatever the basis and understand with the present hospital, you can develop like that. Because I have got 2 centers. But first centers, it is a cardiac center where cardiac transplant itself happening. I took that space and we established in a good way. And all the process was easy, establishing transplant, everything is happening now because I didn't have to go for the too much legal formalities because already that hospital had. So it depends upon how we want to establish. Suppose wherever we want to establish for in the small center or big center, we should see that initially we should not invest in a very big way in the infrastructure. That means better for the youngster, yeah, they can go for a lease basis or rental basis or agreement basis. But I started my second center also, but that is totally different when my finance was stable. So make sure that one pitfall is that whenever you are working your own hospital, make sure that you always take your professional fee first. There is a lot of question whether hospital is in loss or how will well run. But whatever you are doing, even if you are doing a URS, cystoscopy, whatever it is, that there is a professional fee for you, which you should always take and keep it yourself. I think this is the things which I did. It worked out for me.
Thank you very much, sir. Now, the question that arose in my mind after this is, am I good enough to start my own practice, or do I need to work in a group where I have some seniors, some juniors? So I went to Dr. Karthikeyan and put this question to him. So over to you, Dr. Karthikeyan.
Thank you, Dr. Abhishek. So I'm going to take you through about the current status of group practice and how do we practice as a group. So I have framed my talk over these steps. So these are the 4 types of practice in our country. One is the institutional based practice. The second one is the corporate hospital based practice. And the third one is a small hospital, either owned by a neurologist or a neurologist is working in such an hospital. And the fourth is a freelancing urologist. 60% of our urologists are in the last 2 groups, either working in a small hospital or having a small hospital or either doing a freelance. We know urology is a dynamic specialty that has changed incredibly during the past 4 decades. From general urology to subspecialization, the growth of urology is profound and it is the reason for its refinement and development. So when somebody finishes his residency and comes to practice, these are the scenarios in front of him. He doesn't have enough patient volume. For want of brand value or due to market pressures, patients are towards a corporate hospital or a senior consultant. Even if he wants to build an infrastructure, he needs a lot of financial support, and he needs a hospital with a lot of insurance empanelment, as most patients want insurance nowadays. And on top of it, patients want everything under one roof: imaging, laboratory, cardiac evaluation, everything in one hospital. So to circumvent these things, one option is to have a group practice. A group practice is defined as 3 or more doctors formally organized as a legal entity in which business, clinical, and administrative facilities are shared. It definitely improves the quality of healthcare, decreases the cost, and provides a professionally desirable working environment to the practitioners. This is very, very important. The history of group practice is interesting. It was first started by the Mayo brothers, and they are actually called as the fathers of group practice. They started in the late 1800s with no preconceived notion, no preconceived plan. Over time, a lot of Mayo trained physicians came into the country and they have set up their own groups in the different parts of the nation. From US, this idea of group practice is adopted in many countries. So what are the factors that drive towards group practice? As an independent urologist, these are the impetus somebody faces in the start of their career. We know the number of urology seats is ever rising. There is an increased competitive pressure among the urologists. Sometimes hospitals recruit more urologists to strengthen the brand values, and this increases the competition among the urologists within the same hospital. And the economic burden to procure high-end instruments is ever increasing. Because of particular brand value, patients are more towards one setup, or for want of specialty, patients are towards one particular consultant. Moreover, in some places, urologists have formed some regional groups with the referral doctors where they don't refer patients outside their group. So the need for group practice is definitely there. Independent urologists may join a group and develop a group practice for better working atmosphere with autonomy. For want of equity sharing, there may be a group that is definitely more efficient in a group in executing the skills that have been already acquired, or they can acquire a skill faster with the help of the co-mentoring. They can form joint ventures to procure instruments and develop infrastructure, which will help them to have access to modern technology. This is the data from US. In 2006, nearly 60% are in group practice, whereas in 2015, almost 85% of urologists are into group practice. So let us come to our scenario. For want of capital investment towards the use of minimally invasive surgery, we need expensive equipment. This can be achieved with the help of joining in a group. Sometimes graduates from the same institute who settle in one particular part may get organized as a group. Actually, the group practice is well established in periphery than in metros. So these are the benefits of a group practice. You definitely get support from your colleague. At the same time, you will have an autonomy. You can develop new skills, or you can improve your already existing skills. Academic upgradation with subspecialty training is definitely a possibility. The surgical outcomes of your patients definitely improve when you are in a group. Actually, you are the average of the 5 people you commonly move with. And if you move with a highly elegant and excellently skilled group, obviously your results will also improve. With more volumes of patients, the publication rate should increase. And with the having a concept of one family, one group, definitely there will be diversification of subspecialty and the quality of healthcare delivered will be definitely better. Group practice definitely improves the patient safety and the purchasing power of equipments, as well as the insurance acceptability rates are more when you are in a group. One advantage of being in a group is having a better vacation options if you are an individual urologist, which is otherwise very difficult. If I am going to come out for a conference or out of a town, I will not be able to take leave. But in a group, it is possible. Not only the purchasing power of me, but also the sharing of my profit also increases with the help of having a group. Being in a group is not without any disadvantages. Most conflicts occur due to the sharing of money. Other reasons are due to staffing, call coverage, scheduling of the OT, titles. Most people are very fond of having title. Vacation policies may be a point of discussion. Unwillingness to adopt for a common formula for income distribution and expense allocation is one of the commonly undermined factor in a problem among the group. The other challenges are not having a group consensus. Though it is difficult, it is definitely possible and more essential. Egoist attitude without skilled administrative machinery is a definite barrier in a group. Though when we have a trouble, there is also a possibility for troubleshooting also. So what we need to have, we should have a common formula among the group. We should be flexible within the group. The leaders, there should not be any hierarchy. At the same time, the leadership or decision making should be left to everybody and should have a common consensus. The pooling of cases to share the economy is a better strategy. Definitely lending hands when times of emergencies and difficulty within the group helps them to develop a good bonding. As personally, what I have found is that I felt more confident when I operate risky procedures, when I have a group member with me who is a qualified urologist, and he helps me to create awareness about my strengths and weakness. When I am down with my illness or when I am not available due to vacation, my work is not spoiled because it is taken care by the senior or other responsible qualified colleague. We have a foundation called the Trichy Uro Education Foundation, developed by a mentor with a vision. We have 6 urologists having the same wavelength. There is no hierarchy in our group. This is how we practice. We have individual practice 6 urologists in 6 different hospitals, but we commonly work when there is a major case. We have a WhatsApp group. We post the cases in that group and we decide the time depending upon the availability of the other urologists. And if you are needed in other hospital, we will plan our cases accordingly. The work sharing in the absence of fellow urologists is one of the major advantage of our group. Even transplants, major operations in the other hospital will be completely covered by the group. We do have a regular academic meeting with presentations among ourselves. We started having an endourology fellow with us for the past 1.5 years. This is what we have gained by practicing as a group. The patient outcomes have definitely improved after subspecialization and the group formation. Because of the co-mentoring, our learning curve was very well shortened. We have a regular hands-on training program for RIRS and supine PCNL, and we have conducted more than 60 sessions in the past 7 years, and more than 200 urologists have been trained under us. We have the privilege of conducting the first ECRS workshop way back in 2020. And most importantly, the burnout among our group is less because we not only meet for the cases, we do have a family meeting and relaxation time. So as a team is nothing but it's a many hands with one single mind. Working together as a team definitely helps in improving the outcome and the satisfaction rates. Though we are in a team, we are independent with the support of the group. This is the key concept in our group. Though group practice is an uncommon journey, the results are extraordinary. So the take-home message will be, as a dynamic specialty, the subspecialization is the answer for further growth and refinement. Subspecialization along with group practice is going to be the future. Such a transformation with subspecialization and group practice is going to become the norm in India. Thank you.
Thank you, Dr. Karthikeyan. As usual, lucid and extremely informative. Thank you very much. I welcome Dr. Raman Tanwar and also invite his comments for this talk.
Hi, Karthik. This was an absolutely mind-boggling talk, but I have a lot of questions around it. I think making a group is something that you can think about, but there are challenges around keeping that group alive, in the sense, what if somebody out of the 6 has a better practice and then that person tries to dominate? Or what if there is no retention of that particular urologist because he moves out? And then how do you really find that group, that like-minded individual? And you've got 6 of them, so I'm sure you have some experience at hand. But this question is not just for you, it's also for our chairpersons, because they are also mentoring urologists, and of course they must have something to add. So these are just common questions as a moderator that I wanted our audience to be more clear about.
Just one big comment. If you keep money as the byproduct of the group practice, then your group will sustain forever. Our motto is quality work, peace of mind, and money is a byproduct of this group practice, and it is not the first priority.
So we can also ask Ramesh sir and Rajiv sir to make a quick comment, how to retain people and what to do if one of them outshines the others.
I think the underlying principle at the outset, first I'll say that I'm happy that the younger generation is taking up group practice. In my generation, group practice was hardly ever heard in urology. So I'm glad that Karthi and his team have done a wonderful job. In Bangalore too, we have Anmant Raju, Sunil Gowda, all of them are in group practice. So it's pleasing to see this happening. The fundamental thing would of course be that you have like-minded people as a group. If there's a discordant at the way you administer the group, there is going to be a disaster. So if finances are kept in the backstage, it's important, but if it's not the primary ambition for the group, then I'm sure it will succeed well. So like-minded individuals need to be working.
Yeah, that is the key. It should be a give and take approach between the members, because as you said, if money creeps in between, then the group will not sustain. Because earlier, I know about few groups which worked well for a year or so, then it collapsed. Only thing is that there should not be bar, I will be doing this, or you should, in the initial stage itself, there should be understanding that these cases will come to so and so, this will. So there is a guideline for that, and everyone should accept it, and it should be a closely knitted, like-minded people. Here I have by my side Krishna Mohan, who is now going with a sort of a group practice only, so we can get his viewpoints as well. So first of all, as Karthik sir has told, the finance is the one thing we should be very careful. And sometimes our partner may not be so active. So everybody will not be active in a group. Somebody will be having some benefit. Somebody will be more good into admin. Somebody will be more in some procedures. Somebody will be more active. Times the partner will be a senior. So the thing is that group practice should be a complementary to each other and like-mindedness there. If it is there, it's very easy. It can make it very successful, because if some senior is there and almost experienced doctors there, most of the things can be done. It doesn't mean that the senior should always do the case. He should bring the case. Like that, we should not be very much. There should be an understanding between them, because sometimes somebody will be sick. They may have to reduce their work among the group. So all these things depends upon this thing. What I found is that if finance is shared equally, I feel the group practice will be much successful. That mind should be there always. Okay, and always in group practice, the blame should not happen. If anything happens, there should be a combined responsibility to take the burden. That's the key to the success of the group practice. Always never expect that your partner should deliver like you, or sometimes you may not be able to deliver like him. It's just like a marriage, some compromise we have to make always.
Rohit sir, please go ahead.
See, it sounds good to listen to all these things. ये संस्कार वाली बातें सब ठीक है, sir. लेकिन in group practice, I have 3 groups with me. One thing which you need to make clear is, you have to have an entry strategy and you have to have a documented exit strategy. Unless until you have this strategy is clearly documented and
I agree.
nothing works. So
It should be you can do an LLP firm type.
Yes.
Because LLP firm, the partner can get
Thank you for
exit
the
into the group at
comments.
any time.
Perfect, sir. So I think Dr. Zishan has to make a note of this, that group practice has to be further, diversified and dwelled into subsequently in our U sessions, because this is Ram Rajya that we're looking at, group practice, which is not physically, possible in the world. And I think next, we have to learn by examples and take everybody's opinion on how to do it best. And next, let's invite for another very controversial topic on how to select the place to practice, rented or self-owned or single specialty or multi-specialty. And we have Tushar Dhani for this. Welcome.
Thank you, sir. Thank you to all my respected seniors and colleagues. I will be talking about how to select a place to practice, rented versus self-owned, and single specialty versus multi-specialty. So first we will go through rented versus self-owned setup. So I will go through the pros and cons of each. So what are the pros of a rented setup? So as we all know, there is no initial exorbitant investment in a rented setup. Your setup can start functioning very early. You will not have much time for the setup to start functioning. You can get a place in a suitable area, patient-friendly area where patients can walk through easily. They will have better transport facilities. You will not be burdened by a lifelong EMIs, and you will get a good early in-hand income soon in a rented setup. So what are the disadvantages of rented setup? Insecurity, monthly high rentals, lease agreements which will increase yearly or as per your lease agreement. There is a very less scope for expansion of your hospital and modification in a rented setup. Less chances for fulfilling NABH norms in a rented setup. Your initial investment in what you have done in infrastructure and armamentarium and rental what you are giving is ultimately a dead money, because once you move out of that place, that money is gone. You will have you may have interference by your owner that may hassle your progress. And then eventually when you change the place, it will adversely affect the patient flow, because you have to change the place, then your patient flow might change eventually. So what are the advantages of a self-owned setup? So you have a sense of security, that is, this is my place, sense of possession. You have a scope for expansion. You can make it according to your choice and decision. you have a possibility that you can make it according to your NABH, current NABH norms, which we are going to be slowly, it is going to be essential in every hospital setup. There is no fear of lease agreements and hike in rentals. And eventually what your self-owned setup is a high value asset for your family in future. Just in case you stop working or something happens to you, that is your asset for your family. That is what you will leave behind for your family. And you can have a better infrastructure. You can equip your hospital with better armamentarium. So what are the disadvantages of a cell phone setup? Hefty initial investment. The investment will be very high. So as per that, the loans will be high, EMIs will be high. So there will be a long journey before actually your setup start giving you money back. It will take a long time, long journey. And the location may not be patient friendly. You may not get, now you are planning for a cell phone. In next few years, you will search for a place. And as we all know, all of the tier 1, tier 2 cities are already full. So you have to go to little outside. So the patient may not be, it may not be easy for the patient to travel to that place and come to show you. So location may not be a patient friendly. And actually it takes quite long. It takes long time. First you get your land, then you build, then contractors, then your setup, then your staff, maintenance. So actual once you decide to buy a land and from actually you start running the hospital, it takes long time. So one more important issues, like since you are single-handedly, you may not be able to sustain the setup. So you may need partners, maybe working or non-working partners. So you might have partner-related issues in future. And the most important thing, we start thinking of self-owning a hospital after a certain period of time after finishing our training, maybe 4 to 5 years down the line. And as we all know, after super specialty, you are already, your age is 35 near about. So at 40, 45, you start thinking of your cell phone setup that will start functioning in next 5 years. So actually you will start getting benefit from your setup at the age of 50 around. So your age is advanced and you have to give 24-hour time in the initial period so that your setup can run smoothly. So your personal and family life will get affected. That is very important. And obviously the setup will be good. You are not going to be a compromised setup. So your maintenance cost will be very high. So these things are very important when you consider owning a hospital or continuing your practice in a rented setup. Now we go to the second part, single specialty versus multi-specialty. So it actually the single or multi-specialty setup, it remains an independent consideration, depending on what are your long-term professional and financial goals. So most important aspect is your satisfaction, your choice, your preference. That is most important thing. So what is the most important thing? In this era of dramatic change, what are the important questions which needs to be answered before you decide whether in a single setup or multi-specialty setup? That which model will have the financial capital to expand or deal with competition from other hospitals and health system. And the second important is which of the model will accomplish the objective of better health care cost and better patient care. These are the two most important things which should be considered when you are choosing between single and multi-specialty setup. So as we know, size matters. So what is important, super-sized or value-sized? Both things are very important. So simply being big is not sufficient. Strength of the hospital, size of the hospital, they are attractive qualities, but they often come at expense of your speed, agility, and maneuverability. So the patient, once he enters a big multi-specialty setup, his door to OT time or door to ward time is prolonged, is longer than in a single specialty setup. So what are the things we should consider? Professional autonomy, like all of us, we need autonomy in our professional decisions. So that has to be considered. Then risk of fee sharing with other specialty in multi-specialty setup, that should be considered. Administrative complexities in both setups should be considered. And as we all know, the labor and what facility we provide in hospital, they consume around 60 to 70% of your total revenue. So that should be considered in mind. And referral network, which is the backbone for most of us and most of the hospital. The referral network is generally based on financial gain rather than quality patient care. So the referral doctor is more worried about his referral, amount of referral. So in which setup will be better in sustaining your referral network? That also should be considered when you are thinking between that. So for multi-specialty setup. So I work in a both kind of setups. So this is a multi-specialty setup where I work. So what are the issues and advantages? So as you all know, we have a numerous specialty under one roof. It can offer high-end diagnostic in a multi-setup, which may not be possible in a single specialty setup. It stays all days open throughout the year. It will treat all medical emergencies related to your specialty or unrelated to your specialty in your patients. Then one feels more confident in managing a patient with severe comorbidity in a multi-specialty setup because you have various consultants to take care of his other comorbidities. They have a better intensive care facilities in general. And for your family, you may get a privileged care if one of the family members get ill and he requires treatment from other specialties. So if you are a part of a multi-specialty setup, your family, you feel more confident in getting them treated in the setup where you work. So generally it works, multi-specialty, it works in a model of collaboration and collectivism, a team approach, and it offers a one-stop shopping for your consumers. So now the most important problem with a doctor is administrative headache. So central administration in a multi-setup can take care of all hassles related to managing a practice, legal issues, insurance issues, and malpractice issues. And these things can be handled by a central administration in a multi-specialty setup. So assumably multi-specialty emphasis is more on interdependence rather than individualism. So branding, the most important aspect of multi-specialty setup is branding. They are brands like all big brands in India. So that attracts patient. So what are the disadvantages or what are the hassles we face is incremental administration in a multi-specialty setup. You have a junior consultant, you have a senior consultant, you have associate consultant, you have medical superintendent, you have a CEO, you have COO. So you have to go through all those hassles. Then second, your autonomy and decision-making ability decreases in a multi-specialty setup because generally multi-specialty setup eventually become bureaucratic and policy-driven. And then clashes between physicians over admissions because of their revenue model, referrals, working hour. That is the one important issue in a multi-specialty setup. And as most of us know, the urologist generally gets lesser privileges in a multi-specialty branded setup because they are considered as less revenue generating as compared to their cardiology or neurosurgery counterpart. Though the number of patients are more, patient flow is more with us, but the patient stay and expenses are more with a cardiologist or neurosurgeons. So generally we are given less preference in a multi-specialty branded setup. So now about single specialty setup where I work, it is single specialty, one more setup in our place. So single specialty generally has a higher compensation, more agile decision making, avoids complicated governance and management issues. Your timings are flexible. You don't have to stick to a 9 to 5 timing as in multi-specialty setup. It is easier to manage patients' financial issues, especially when there are some operative complications in a single specialty setup, because single specialty setup, all associated neurosurgeons with you, they will understand the complication and that has to be managed. So that is easier in a single specialty setup. You don't need to take a multi-step permission process to purchase or procure any new armamentarium, your salary hike or discounts of patient as compared to a multi-specialty setup. And the most important thing is you don't want to be under constant surveillance like in multi-specialty setup and biometric attendance. So in a single specialty setup, you think you are your own. So you are not under surveillance. So as we all know, the single specialty setup market is growing very rapidly in India over past few decades. The most important thing is that it is more comforting for a patient to walk into a single specialty as they typically look less intimidating than a multi-specialty huge setups. And single specialty offer a custom solution for a specific requirement by a single specialty chain with specialized infrastructure and trained staff from the door is the most important highlight of a single specialty setup. So as we all know, single specialty can be extremely rewarding, but likewise can be equally challenging. So there is no shame in hard work, as every one of us know, and Rohit sir has told. It is no shame in being compensated fairly for one's effort. We have trained for years to perform procedures that are technically and physically demanding. Income, what we are generating is hard-earned income. So have no shame in earning earn as much as you can, learn as much as you can, have fun as much as you can in the setup of your preference and comfort. That is most important thing. And the last, it's better to die with memories than dreams. Thank you, sir.
Thank you, Dr. Tushar. That was wonderful presentation, to say the least. One question was that when you are talking about group practice, what about multidisciplinary group practice? Means if I want to collaborate with a GI surgeon, vascular surgeon, so how does that work?
What I have seen in my area, sir, I have seen a big multi-specialty setup with different specialties coming together. The most important thing, what I feel in a group practice or a setup when you own, either the partner should be professionally related or personally related. Professionally unrelated and personal unrelated partnership generally ends up in troubles because the revenue generation will be different when you are collaborating with a GI surgeon or a neurosurgeon. Eventually, if you are not, if you are friends, if you are very known to each other personally, then it might end well. But if you are unknown to each other and you are coming together, then you might have problems later.
Okay, so wonderful talk and very nice reply to this. First, I wanted to understand from our chairpersons if they have any other comments that they want to give to this talk, because this talk invites a lot of questions, and I'm sure everybody has something to add on to this. Right. So I would you suggest that people should try the different modes of practice? Maybe they should also start with their own small clinic and then join a corporate or a multi-specialty and see what suits their flavor, because many times you don't know. As a person, when I start my practice, I don't know what's gonna hit me right. So is it a good idea for somebody to start to try different levels, side by side start his clinic? How would you take it if you were somebody who was starting?
Like how I started, sir, I joined a multi-specialty setup so that I can get a salary initially to run my family, and simultaneously I search where a single specialty setup is working, and so that my professional need, my skills should also improve, because in a multi-specialty setup, if I'm alone, I may not improve. It'll be difficult for me to improve my surgical skill. So I joined them as well. So I think the best part is to start with a multi setup so that you can have sustainable income initially, and then search for like-minded groups, and you can start a single specialty setup.
I think that is the kind of answer that I was needing. We can try, we can try multiple things. There's no harm. We don't know where we are going. We don't know what's gonna, hit us ultimately, where we're gonna gel. So it's always good to try things, and you can always move back to places. Thank you so much for this wonderful talk. And if you've started,
can I make a point? Small point.
Yeah, small point.
See,
please.
the question is uni-speciality versus multi-speciality. We have in Ahmedabad group of 4 or 5 urologists establishing a uni-speciality. When they started that thing, we had a discussion, and I always suggested them to have a multi-specialty. This COVID 2 years taught them in a very hard way. It's always better. There are multi-specialty setups, they earned out of COVID and they sustained. The uni-specialty setup, they faced a lot of problems.
I appreciate it. Thank you, Dr. Rohit. So now if you want to start your clinic, because that's something that everybody should do, at least have a backup. So for that, how to start that OPD and indoor construction, for that, I'm going to have an excellent talk. I'm sure I'm anticipating a wonderful talk by Dr. Anish Gupta.
Good afternoon, everybody. An off-subject topic for me, basically. But I learned a lot of new things when I was doing research on this. I'm going to restrict completely on construction. Land has been talked about, whether you are purchasing it, whether you are renting it, whether it is on lease. I am not going to focus on any of those because we've talked about it. I start with something, this is acrostic poetry. The first words join to form a meaningful word. Cared for a dream to make something big. Always wanted to make a place of my own. A structure where healing occurs with care, compassion, and utmost sincerity. Forgot in the process the costs involved, letting go of precious time and resources. only if I had taken into account time and everything else involved, would this not be a monolith, but a hospital I dreamt of. So I'm going to go retrograde actually. I'm not going to start with the cost of construction. I'm going to start with what is more important than the cost of construction is the cash flow. See, where do most of the projects fail? I talked to 6 hospital planners. There are 2 kinds of people building hospitals as of today. A, it might be a group or a single person. B, backing up from an investor or a big corporate building the hospital. On an average, he says 80% of projects built by a group or a single person are delayed. But a corporate project always runs on time because the cash flow is not an issue. COVID hai, there is a gap in construction for 6 months. Everything cost goes up. It hasn't been taken into account and the delays start. So this is the mother cow which needs to be taken care of. So the budgeting has to be done with adequate provision for delays. Delays increase the cost and vendors may disappear midway. And as I explained, this is the most common reason for failure of projects. The next thing is also as important. You can't build a structure and say that this will sustain. The operational costs have to be taken into account. It might be 6 months to 12 months before your OPD. Suppose I've been doing OPD at X place, and at the same place I start an OPD nearby, I will probably be able to have good ROI if I'm an established doctor. But if I'm a new person coming into it, it may take 12 months before I start getting return on my investment. This goes up to 5 years depending on the size of the hospital actually. From 12 months to 24 months is average, but it can go up to 60 months also. And you need to have that much provision for finances to cover up without your investing giving you any returns. The third thing is that there is a concept of gradual inclusion and expansion. You can't do everything in one go. You can't buy a 100-watt laser in one go. You can't buy a Thulep at the same time. You can't have the best Siam at the same time. You can't have everything. So you really need to grow accordingly. Let's say you build a 100-bedded hospital. You would probably just equip it initially with 30 beds. You will not equip it with 100 beds in a go. The structure is ready, which I'll talk about. Once the structure is ready, you can implement further projects midway. You will also get some cash. So that is how that would work. Okay, what is involved in hospital construction? Basic things. The most important being civil, which is the structure. Then comes the mechanical, electrical, and plumbing, which is in hospital planning terms called MEP. MEP is the term. Everything comes in electricals. Wiring, switches, light, plumbing, everything comes. Sewage, equipping the bathrooms, provision for drinking water, RO plant, everything comes there. Finishing, how do you want it to look? Now that is something which will increase the cost. Are you going to do it in a 8-tier city, a first-tier city, a second or third-tier city? What are you looking at? Accordingly, the costs go up. Air conditioning. Are you looking at a centralized air conditioning, which is probably what is required in at least a first-tier city right now if you're making a hospital, which would again bring up the costs. This does not take into account the gas pipelines, modular roti, nurse call system, CSSG, kitchen and laundry. Why are we talking about all this? Because we want to build what is known as a level 2 hospital. The Clinic Establishment Act makes hospitals into 4 categories. Level 1 basically provides for medicine, pediatrics, gynecology with a minor OT. Probably they can do MTBs. I don't think they can do any procedure without a anesthetist. So the concept for level 2 is everything of level 1 plus a surgery OT plus a anesthetist. Imaging and laboratory services may be optional or outsourced. OPD. What do you need for OPD? So I'm completing this part together so that I come to the cost together. You need reception, you need chambers, you might need a pharmacy. Minor OT for a urologist is must. You have to have a ramp, stairs, and utilities. So size of hospital is very important. It now comes down to everything is calculated per bed. You want to build a 20-bedded hospital, you want to build a 100-bedded hospital. It doesn't make a difference according to hospital planners. The cost remains the same. So it is all calculated per bed. This is clearly given down in CEA guidelines. And this is picked up from there. A hospital size should be basically around 410 square feet carpet area per bed. So if you want to build a 20-bedded hospital, you need around 8,500 carpet area square feet. Now you have it divided on 2 floors, 3 floors, that is up to you. But you need that kind of a area, without which you will not get an ABH. The ward bed, including circulating space, they add 30% for the circulating space in every instance. So I've added that. It's 100 square feet per bed. ICU goes up to 150. Corridors can vary. 8 is minimum. You can go up to 10 and 12 as well. Reception, again, it depends on how big a hospital you are making. It may be 1,200 square feet or it may be 2,000 square feet. 25 bedded probably does not require more than 1,200 if you're looking at just 3 or 4 doctors doing OPD. OPD chambers require around 120 square feet per chamber. The pharmacy should be adequate to contain 5% of total visits to OPD in any given session. Now you need to calculate what would be the footfall, and accordingly you need to calculate that if we have 5, if my footfall is going to be 50, that means I'm just looking at 2 people standing at the pharmacy at any given point of time. But if I expect my footfall to be 250, then I'm looking at probably 13 people standing in the pharmacy at any given point of time. So accordingly, I need to build the pharmacy. Minor OT is mandated to be minimum 150 square feet. Now, these are minimums. If anyone's been to AIG last year when we came to Insurance Con and they took the round with us, they would have seen that, you know, Dr. Nageshwar Reddy's gone much beyond these levels. But this is minimum. You can't go below this. Major OT is around 300 to 500 square feet. Why I put 500 is now we have a lot of people buying robots. So it does increase the space tremendously. Biomedical waste, BMW is what we call it. It can go up from 70 to 240 depending on the bed strength of the hospital. Costs, the most important part. Civil without basement comes to around 1,200 rupees per square feet. Whatever you place, you may choose. A state with a A-tier city, B-tier city, or a C-tier city. MEP, again, mechanical, electrical, plumbing, goes to around 1,800 to 2,000. Now, this can go down to 1,200 if you are in a C-tier city. But for an A-tier city, you need air conditioning, which will go up to 2,000. The gas pipelines, modular OT, CSSG, nurse call system, kitchen, laundry, again go up to 1,200 per square feet. Miscellaneous added to around 600 per square feet makes it around 6,000 rupees per square feet is the cost of development. And I just talked to you about 8,500 square feet. And we multiply it by 6,000. So we are looking at an expense of, anyone that good in maths? So we are looking at a very substantial expense. We're looking at an expense of around 4 crore rupees, 4 to 4.5 crore rupees just to build the structure. No, That is what I started off with, that you already have the land from the previous speaker. He already got you the land. I'm just building you the hospital. This includes the ICU, but it does not include the equipment, which is another mother cow. And what happens, I'll come to that equipment part. This is a reception. If you're just building an OPD, a lot of people want to build OPD clinics. So if you just want to build an OPD clinic, reception, 3 OPD chambers, pharmacy, minor OT, it costs around 2,600 for the entire project execution, including civil and MEP. Ramps, chairs, utility around 200 plus square feet. Again, I left equipment there as a blank. What did the hospital planners tell me is that the doctors plan everything, but they exhaust their resources by the time it comes to equipment. And they really don't know what to do with buying instruments thereafter, buying basic surgical instruments, basic surgical workstations, or high-end machines, what may be the case. Let's take an example of a hospital bed. You can get a hospital bed for 20,000 rupees and you can get one for 2.5 lakh rupees. If you don't take the budgeting of equipment into account, even if everything is ready, the hospital will not start because you will not be able to equip it. So this should be taken into consideration with when you're starting the project, if it's a hospital, with inflation adjusted for the equipment and a 10 to 15% rise of cost of the equipment increasing when you will buy it, because it may be a year before you might buy the equipment. Furniture, OT and equipment, what do you want to buy? Keep in account the ROI, CMC, depreciation and insurance. And again, as I said, don't go for everything in one go. This is from a recent example from a urologist from a second-tier city. He's made a OPD chamber. Total expense he is done is around 12 lakhs. It is a rented place. He has done the MEP of that and the finishing with equipment, basic equipment for a minor OT. So what does he have? He has a ground floor with a small ramp, 3 cabins, one for his wife, I think who's a pediatrician, himself a urologist, and one if anyone else wants to join in. A minor OT, 2 patient beds for daycare surgeries, 1 staff room, attached bathroom, 3 utilities in all, one for the Euroflow, one for patients and the other in the staff room. Size of the hall is around 23 into 45 feet. I already told you the initial cost. The recurring cost is also to be understood. 15,000 per month for the staff, 8,000 for the pharmacist, 23, 25,000 for the rent, 48, 15 for the electricity, 63, BMW, 66. 12 months, this ROI there is no ROI. So you need to keep 8 lakh rupees more before you starting break even. So you need to earn 66,000 rupees from that OPD to start breaking even. Only then it will become successful. Staffing is 1 trained staff cum receptionist, 1 pharmacist and 1 class 4 worker. I found it lacking that he's not having anyone with him in the minor OT. Who will assist him, I don't know. So there's probably one more addition which is going to occur in his minor OT eventually, because the receptionist can't go and do operate also with him. So I think his expenses will go up to 80,000 rupees per month, which makes it around 10 lakh rupees for 1 year before he starts earning money. This is about it, because I was just given a mandate to tell you the costs involved in construction. 2 people I want to acknowledge who immensely helped me, Dr. Rajesh Kukreja sir. He given a similar talk about his hospital recently, which I heard, and then I told him to share the presentation, which he did very graciously. And one is a very close friend of mine, Dr. Ashish Roy, who's a hospital planner. I'll end by this. You know, making a hospital of your own is a dream for many. Many fail. Don't go by the success stories of others. Assess and plan wisely. Thank you so much.
Thank you, Dr. Anish, for the wonderful talk as expected. I would like to, you've covered everything exhaustively, of course, but I would like to, take the experience of our chairperson on this, that if you want to start an OPD or a small hospital like Dr. Anish has advised, anything else that we have to take into account in this regard, sir?
No, actually, I started hospital first, and then I started the clinic. Okay, we have 2 centers, but one thing I understood that the amount which getting as a profit from a large hospital, including we have got 100-watt laser, transplant, 15-bed ICU, everything. And equally, I have set up a good, you can say, 5-star clinic with the Euroflow, pharmacy, and all these things. And minor procedures, mostly we are doing cystoscopy and stapler circumcision. At the end of the month, I found clinic is most viable.
Thank you, sir. So I think I would also like to add my personal experience onto this is that if whatever kind of, thing you want to plan for the future, there's no harm in starting your own clinic, maybe in the basement of your house, or maybe, in a commercial area nearby, and keep building upon it slowly. And, as you said, you don't have to.
It's scaling. It's always scaling. You can't go it all in one go.
All in one go. So don't make that mistake. See how things go, test yourself, give yourself some space, and be kind to yourself as well whenever you're starting.
I know a urologist, very close to me, and he's started building a 200-bedded hospital. And it's been 6 years. 2 years COVID came. And I talked to the hospital planner who's associated with him, and he said, sir, the cash has dried up. And now with the cash drying up, I initially told him that you just start with 50. Now he's half equipped. Some of the hospital beds are there. But he doesn't have the money for now rest of the things. All the 200 hospital beds are there. But he doesn't have money for now the further equipment. So you must plan. You can't go 200, and you're not going to get 200 patients for admission in one day. You'll gradually scale it up. And when you have 200 patients, you'll start making money enough, then you can always expand. When the occupancy should be at least 80 to 90% at any given point of time, then I would agree that you can scale up. Otherwise, it's impossible for you to get your money back. So it's very hard. I'm not discouraging people, but I'm telling you it's very hard as of today to do this unless you have corporate backing.
Always consider that diagnostic part, because never think the treatment part of surgical part is generating money. The diagnostic part and the pharmacy and laboratory are major income generators which can be earned in a small setup. That's
Yes,
what I have learned.
Very true, sir. Very true.
We did the cost analysis of revenues in our hospital, and we found nearly about 50 to 60% of the revenues is from the pharmacy and the lab. And the revenue of any inpatient bill, the maximum amount is generated within the first 48 or 72 hours of a hospital stay. The rest of it is only rental of the room. The bulk of the revenue comes in the first 2 or 3 days.
Very true, sir. Very true.
So what about the hospital canteen? The canteen is another area which is like for MPUH, canteen is always the area which is
Canteen doesn't
beneficial.
generate ROI.
Yeah, it doesn't.
It doesn't give you money.
If you see, Abhishek,
it is a facility you're providing, but it doesn't generate money.
No, that's what I'm telling you. MPUH statistics, the canteen and pharmacy are the cash cows. So
no, that canteen must be supplying the food for the hospital patients also. So most of these kitchen services or canteen services are outsourced in majority of the hospitals.
Yes.
The hospital owner or administrator.
There is a contractor who takes the contract here.
Yeah, exactly. So
No, but I agree. It may be giving money to some hospital, but it cannot be the major for most of them. But as sir rightly pointed out, pharmacy has to be your own. You can't outsource, or if you have outsourced the pharmacy, you must have a very good MOU that this is the percentage I'm going to get. Because in Delhi, that concept has started coming that you outsource the pharmacy. And there is a group of companies who are doing this for many hospitals.
That is because maintaining an inventory of the pharmacy without pilferages is very difficult.
Yes, I
So
agree.
you outsource it to somebody who is an expert in this, then it becomes all right.
Yes.
Thank you, Dr. Anish, for your candid opinions as always. Now I invite Dr. Sachin Bote for his talk on personal indemnity and professional indemnity.
Good morning, everyone. I'm grateful. I'm thankful to USI Youth Organizing Committee for giving me the opportunity. And I'm thankful to Dr. Lalahari Cha sir and Dr. Amit Gaur for his help and support. And few of the slides and the information has been taken from them. I'm thankful to my mentor, Dr. Ramnath Bhute. Now, this indemnity. Indemnity means what? Indemnity is actually, it protects us from the loss. Now, which loss? The professional loss due to the claim made by the patients against you. Now, this indemnity won't protect against the loss of fame or name by the claims or the court cases, but indemnity protects financially. So we have been heard about this. Now the judicial system is more of patient friendly, and they are not like friendly to us. So now they are awarding more and more compensation against the cases. So now आजकल ऐसे है कि शनि भारी है, मतलब हमारे प्रोफेशन के ऊपर शनि भारी है. Now insurances, apart from this indemnity insurance, the 4 insurances are important, like health insurance, term insurance, and these insurance. But along with that, professional indemnity insurance is must. I have few of my friends, they even after the 3 years, 4 years of practice, or even 8 years of practice like me, few of them, they don't have the professional indemnity. So this indemnity insurance include the personal and the hospital. So why? We all know why, but still some of us, they don't take it. How much, which company or which insurance and which precautions. Now, actually exact words in the policy are this insurance, this professional indemnity is supposed to protect you from the claims arising out of bodily injury or death of any patient caused by alleged to have been caused by your error, omission, or your professional negligence due to your professional service rendered by you or your qualified assistant also. So it indemnifies you against your liability to pay compensation to a patient as awarded by a court. So they can also reimburse the lawyer fees. Now this indemnity insurance protects against the claims for your negligence, act of omission, commission, your civil claims. Now these criminal claims won't be entertained by this professional indemnity insurance. Now they will pay the lawyer's fees also, but for that, initially when you take this policy, you have to read the fine print, you have to read the inclusion criteria, exclusion criteria. They will reimburse the compensation by the court and the consumer forum. Now, they will, the scope of this indemnity insurance is only the legal liability, loss or damage by professional negligence, no any moral liability. Now, conditions for this is there has to be a contractual relationship between the patient and the doctor for the duty and care. And the patient should prove the breach of duty to exercise care, competence, and skill. They should prove the breach of duty or negligence has caused loss, damage to the client. Now, risk, it is in relation with your professional service, your actions, and the claim by the third party. So third party over here is the patient.
And why we need this professional indemnity? Because we all know that there are rising claims against the doctors due to the change in behavior and break in patient-doctor relationship. Now we can't help much over here because the awareness of patients is increasing, but still we can improve our patient-doctor relationship. Now the sum of compensation are also increasing. Few years ago, maybe 10 years or 20 years ago, the sum of compensation were very less, and even the courts were much in the favor of a doctor. But nowadays, the rising sum of compensation can be problematic. Now, no doctor should practice our medicine or our profession even for a single day without being covered by professional liability. Why? Because these policies won't cover a retro active, like they won't cover before the issuance of the policy any claim. Now the two important policies for us is individual personal indemnity, and another is named as errors and omission. Means it is a hospital establishment policy. It includes your hospital, your staff, and also you. So this hospital policy will include you, but your individual policy won't include your staff or your hospital. So the hospital owners must have this both individual and hospital establishment policy, because if you have only hospital policy and if you go outside to do any operative intervention, that policy won't cover you as an individual. So establishment, this hospital establishment are considered as a separate legal entity under the law. So they must have a separate indemnity policy. Now, while filling the any insurance form, be careful. Don't just sign and give that form to agent to fill, because they don't know exact thing. So always fill the form yourself. In a hospital policy, they have one question that do you have a qualified nursing staff? Because this requirement of a qualified staff is must. So you have to answer it. If you don't have a qualified staff, just mention the staff is trained, experienced, but not qualified. This may increase your premium amount, but that's okay. Now you have to preserve the copy of proposal form if any claim arises. Check policy document for inaccuracies and read the fine print and exclusion inclusion criteria before. Preserve past policy documents also. And you have to do renewal of your policy without a single day break. This is most important. Now this retroactive, the date when you first commence your policy and continue without any break. Any claim after that will be entertained. If there was a gap in the policy and you then restarted, the retroactive date will change to the date you restarted. Claims before this date will not be entertained by insurance company. Now, even after post retirement, you may require this insurance at least for next 3 to 5 years, because the patient can put a claim even after the 3 years of incident also. So even for that 3 to 4 years, you have to have some insurance. Now, this is most important part, and some of us, they don't know about this AOY and AOO ratio in an indemnity policy. Because if agent is good, then he may just advise you that take a proper AOY and AOA. AOY means any 1 year and any one occurrence. Means any event, even the multiple event in that year can be entertained by the insurance company. They give 4 options, 1:1, 2, 3, 4. As the options increases, like if the indemnity is 1:4, it can come at a low premium, but don't go for that. Why? Because if you select a policy with AOY and AO as a 1:2 or 1:4, then in the event of claim, you will be entitled to only 25% or 50% of sum for that incident. Remaining sum can be claimed if they unfortunately another event occurs. That's why you have to choose 1:1. Suppose you have the indemnity of 10 lakhs and you have a claim of suppose 8 lakhs. If you choose for 1:1, the insurance company will give a total 8 lakh compensation. But if you choose a 1:4 or 1:2, out of this 8 lakh, the company will give only 25% if you choose 1:4 and 50% if you choose 1:2. So that's why go for 1:1 ratio. Now this third party claim against the insurer, and claim has to be made during that policy period, and it is under jurisdiction of Indian courts only. Now important points like accurate record, then principle of contribution. If you have 2 or more policies, this principle of contribution always play a role for all insurances, and that you can claim the remaining amount from other policy also. Now, when you take an insurance policy, a free look period for 30 days is there. If you don't, if you don't find that agency is good, then you can cancel that policy within 30 days. Every claim paid reduces that indemnity. Obviously, if you have a policy of 10 lakhs and if you had a claim of say 5 lakhs, then that for next claim, the amount will be only 5 lakh. If company disclaim your liability and such claim not subject to matter of suit. So if you don't escalate the suit, then within 12 months, then claim deemed abandoned. And after 12 months, you cannot go to company and ask for reimbursement. Now this, how they calculate the premium. Premium amount depends on your sum insured. If you take a 50 lakh, 1 crore or 2 crore, then the premium will be high. Your specialization, like operative branches, those high risk branches, even our operative branches, the anesthesia, these branches having high risk, they have to pay a higher premium. AOY, AOA ratio, if you choose a 1:1, then obviously insurance company will increase your premium, but that's okay if they offer some discount. Now, this is important, that what are the standard exclusions. Now, any liability arising out of criminal act or act in a violation of a law is excluded from insurance. Evidence of providing professional service under influence of alcohol. If the lawyer proves that the doctor was under the influence of alcohol, insurance company will not pay the claim. Liability arising out of HIV cases, liability arising out of cosmetic procedures, then defamation, slander, false arrest, or loss of the goodwill or market. This cannot be compensated by the insurance company. Even the fine and penalties put on the hospital or the doctor by authorities cannot be entertained by this insurance company. Now, how much? How much? There is no fixed answer, as one shirt cannot suit all. It depends on your area of practice, whether you are in a tier 1, tier 2, or tier 3. Your clientele, like in a tier 1, this clientele are rich, or they are affordable, they have the insurances, they are educated, so they may claim for higher. In a tier 3 city or a small town, the people may not claim for much. And another thing, that compensation will be this calculated by the court as per the life expectancy, their income, means how much earning they have and how much remaining life they have. So their earning and their social status is also important when the court calculate the amount. So obviously, if the patient was a main earner of a family, he has a big job, then obviously the court will award higher amount. The surgeons and other doing high risk procedures should have more insurance. Now, in recent Consumer Protection Act of 2019, they have raised the financial jurisdiction of the forums. Earlier it was different, but now the district commission, they can hear the cases up to 50 lakh claim, state commission 50 lakh to 2 crore, and national commissions about 2 crore. It is highly advisable to insure higher amounts. Now, better to be over-insured than under-insured. Now, which one? We have different options. Now, scheme by a professional medical association whose member you are can be a good one. Inquire about that insurance company, its authenticity, their track record, year of commencement of the scheme. The longer the duration, it is better. The larger number of doctors taken that scheme is better. Special features like whether they provide out of court settlement, because sometime we may have to go for this also. Now the cost of insurance and the experience of your colleagues, what unfortunate experience. We have few examples like AMC, like that is Association of Medical Consultant Mumbai. They also have a good indemnity. IMA, these IMAs have a professional indemnity scheme like the state of Gujarat. Their IMA has a very good professional indemnity scheme. Now this general insurance companies like New India and Oriental, they also have a good insurance. Now, Apex, they have a personal and this hospital establishment also. I think many have this Apex agency for their hospital establishment. Now this indemnity will include the legal fee. The choice of a lawyer or expert is to you. So you can have a look into their list of the lawyers. You can check their track records and then you can choose. Interaction with a lawyer is important. Sometimes these New India Insurance and these insurance companies, they give a small fee to this lawyer. So many good lawyers, they are not interested. So you can go to that lawyer personally. You can have a talk with them, and if they want a higher charge, then you pay individually. Now this documentation of your hospital records, your patient record, history, and everything is very important, because poor documentation is poor defense, and the no documentation is no defense. So even if you have an indemnity insurance and if you don't have a proper documentation, your lawyer can't help you. So the take home message: no doctor should practice even for a single day without this insurance unless he wants to get into a situation in which he can repent at his leisure. Indemnity insurance is must. Take personal and hospital insurance separately. Adequate cover is must. Thank you.
Thank you, Dr. Sachin, for this talk. You've covered it quite extensively. Since we are also running short of time now, any quick comments from the chairperson, sir? We would like to welcome that, and then.
Yeah, a few things which Sachin has highlighted. It's a must for all the things, and especially the urologists now who are doing high risk surgeries. It's quite mandatory. Next thing is that there should not be a gap between the previous insurance, that renewal should be done on time. And these salient points which we were not knowing, but one of the agent only highlighted this 1:1 and other thing, because we normally give the check to the agent and they will take your name and they fill up on their own. And these are the common mistakes, these are very salient points. Thank you for highlighting everything.
Thank you.
Can I ask a question? Yes, please. Is it better to go for a group indemnity insurance or a personal one, like by either from Apex or one through IMA or something like that?
So it's yeah.
Separately with you, sorry.
Thank you then, and then let's now discuss another important topic, which is about which instruments you have to start with. What are the costs of this? So I have Dr. Sunil Gowda to help with this, an important topic, of course, for our young urologists.
Good afternoon. I know you're all angry and I'll not take much time. I'll be running through this presentation. Thanks for USI and Youth USI for giving me this opportunity. My talk is restricted only to urology instrument. Let me be clear. I don't have any conflict of interest with any of the companies. So whenever we decide to buy an instrument, there are a few things which we should consider. First thing is the type and place of practice. the instrument with which we are trained during our training periods. Of course, the economics, that means how much we are ready to invest for our instrument. And we should take into account what are the instruments used by our colleagues practicing in nearby areas. This is the last point is a very important thing, because if there is some malfunction in the instrument, then you can easily take your colleagues' help and you can complete the procedure and come out of such situation. So for the youngsters, one important thing is remember, buying an instrument is like a successful marriage. You should make a right choice before buying an instrument. And one more important thing is people who are in private practice will be knowing this. We should take care of our instrument very well. We should wash our instrument and we should take care of our instrument very well, similarly as we take care of our wives. So as I told you, urological practice, if you are going into corporate hospitals, you don't have to worry about it. You have to get adjusted and you have to get adjusted with the instrument what they are already having. If you are practicing in a private and teaching institutions, again, the teaching institution will have the set of instruments where you don't have to bother about much and you have to get adjusted to it. But the main thing is the last group, that is a private practice. Once you want to set up your own private practice, then there comes the issue, which one to buy, what to buy, and how to buy. There are many instruments. First thing is the German make or the Indian make. One Indian make instrument is a big no. The main difference between the two is the make or the material used. See, all the German and the German make instrument use a titanium steel, which is about 50% weight, which is lightweight, and it is twice as strong as the stainless steel, whereas Indian instrument, a big no, because they're mainly made of stainless steel and brass alloy. Although we have got many instrument companies, Indian companies who are manufacturing, sad thing is we are not able to meet up to this thing of our German instruments. Again, for the sake of youngsters, we have got upper unit tract instrument and lower unit tract instrument. Plan accordingly which one to buy and decide. Lower unit tract instruments, we know we have got a cystoscope and TRP sheets with this, we have working element. And this one thing is, again, while we make a choice about working element, make sure which one you're buying, which one you're acquainted with, whether it's active or passive. We have got hybrid working elements available. So whenever we are making a choice of working element, make sure that you take a working element which is you're compatible both for your laser work as well as for the bipolar work. And one important thing is we should be able to work with inner sheath alone. So when you're making a choice of this working element, make sure that you buy a non-rotating thing so that only we can operate with inner sheath alone when the need arises. So upper unit tract instruments, we have got nephroscopes and we have got two types, universal, Dresden. So make a choice accordingly with what you are well versed with and make a wise choice. We have got probably most of us are using a Wolf nephroscope, that is Dresden, which is important. Other accessory things associated with upper unit tract like dilator set, balloon dilators, all these things has to be planned whenever we are planning a upper unit tract, buying a upper unit tract instruments. As we all know, the technology is advancing every day. We are coming up with new technologies. For example, flexible ureteroscopes, we have got conventional and we have got disposable. Every 3 months, we are getting a new scopes into the market and each has got its own advantage and disadvantage. Of course, we can't think of buying every instrument. So whenever we are first planning, we should make a wise choice. And lasers also, we've got thulium fiber laser, holmium laser, and many companies are coming up with this. So we have to make a wise choice. And accessory instrument to begin with, when you're starting up your practice, there are a lot of accessory instrument. I think most of the urologists who start their practice, they should not get compromised with a electrosurgical unit. You need to have a good electrosurgical unit, either monopolar and as well as bipolar is preferable, so that it will be useful to you. So lithotripsy machine, that is for a practicing urologist who go to the different places. Yeah, we can have a lithotripsy machine. We have got many Indian companies who are done very well with this lithotripsy machine. We can use this Indian machine. Imaging system, yeah, most of the now hospitals are being equipped with a imaging system, and we have got a single chip camera. We have got HD high definition unit. All these things can be used, and make a choice according to your financial cost situation whenever you're buying. Costing, the most important point is this one. There's no regulatory body to control the cost of this instrument. And even if I pay, whether I'm getting the authentic instrument or whether I'm getting a refurbished instrument, no one is there to tell me. This is the main point, this thing. No, if I ask for a quote, if I ask for a ureteroscope quote, what quote I get will be different from what quote the person gets in a Delhi. I don't know what is the difference, whether there is any difference in the taxing policy or whether the difference in the dealers. I personally feel there is some difference in the dealers because the costing is definitely different. What quote I get is definitely different. So we should be have I'll be telling in the conclusion about this. And there are many, for the urologists who set up their practice, there are many PG packages available by standard companies. I think whenever you are going with this PG packages, please be wise, go through what all is there in the package and then take a decision, because there are certain things which may not use, which you may not like it or which you may not use. So whenever you are making a choice, be careful about this packages. It's very attractive from the financial point of view, but what is there not ready to give you instrument loan, but at the same time, they'll be ready to give you personal loans with a high rate of interest. So with this, the need of our is we should have to regulate, there should be some regulatory bodies to regulate the prices of the instrument. And there should be some updation of this instrument charges in some website so that it will be a reference for all the urologists who will be planning to buy the instrument. Finally, since we have got many people from USI and other people around, there should be some financial tie-up with banks through regulatory body, which can help the young urologists to procure instrument of their choice. Thank you.
Thank you, Dr. Sunil, for this comprehensive talk. Just two quick questions. One is that should you buy an instrument before you clear your postdoctoral? That's one.
Definitely.
And should everybody be required to buy it, or should they be given time to buy it?
It's definitely
Second, do you
no.
want to take some help from seniors, or what would you do now if you were to buy your instruments?
It's definitely no, when you're doing a post-graduation, it's definitely not, it's not worth to buy instrument at that point, because the teaching institution or the institution where your practice will be having the instrument. So it's definitely not, it's definitely no when you're doing this thing. But once you come out, as I already told you, you decide where you are going to practice. If you're starting your private practice, yeah, definitely. Keeping that in mind, I made my presentation. Okay, if you're starting your private practice, yeah, you go through, take the help of your seniors, go through this thing, and then plan what all you want, and then purchase the instrument.
Sir, do you insure your instruments?
I've inquired about this also. None of the instrument companies are ready to instrument this endoscopic equipments. They tell no, there's no instant cover to the instrument as well.
But things like laser, lithotripsy machines.
Lithotripsy machine also, see, we have a lithotripsy machine. We inquired about this lithotripsy when we bought the new Dornier machine, which was worth about 63 lakhs. For that machine also, there was no insurance available at that time.
So my question to seniors is, if somebody approaches you as a junior urologist, how can you help them? As in, like, we have to give a message to our crowd who is listening online and offline. How can people approach a senior? Would they be willing to help? We have many seniors here. How should the juniors really tackle this problem of buying an instrument?
See, the fundamentals will be, most of the teaching hospitals have high-end equipment. If you go for a camera, almost all teaching hospitals will have an HD camera, and they allow all the modern gadgets, and you will all be trained by doing the best of the equipment. None of the institutions will train you with Indian instruments. All of them will be having either Olympus, Karl Storz, or Wolf. So you get your hands-on training using all the high-end equipment. So you need to take a decision depending on the financial backing that you have. What is it that you want to buy and how much of it you want to buy? A rule of thumb I tell all my residents is, start by investing in just the lower track, right? Basic cystoscopy, TUR, VIU, and a ureteroscope. Straight away, don't go in for a PCNL. Unless you have your own hospital and stuff like that, if you're going to do freelance urology, just see which area you're going to settle, and based on that, you buy your equipment. Nowadays, equipment is available for hire. Laser machines are available for rental. All of you know about it. Flexible ureteroscopes also available for rental. So if you're going to do freelance urology and that's how you're going to start your career, buy minimum equipment that you are familiar with. You don't want to use equipment that you're not familiar with, or you don't want to use equipment that are not good and sustainable. So it's better to buy equipment that you are used in your training period and which will be long lasting for your careers. Start small and then build up as your practice builds up. Set aside a certain amount to repay your loans. Set aside a certain amount to buy new equipment as you move along. Don't compromise by buying bad equipment. That is going to give you trouble some point in your career.
So I would like to add one more point. If you're going for a good gadgets, we are going for the bank finance, but always ask the company. Company will be always having a finance scheme. So the thing is that if we take the company scheme, for example, any company, they are going their own finance scheme for doctors. The benefit is that till we pay the loan or anything pay back, the thing is that their link with us will be always be there. Only thing is that if you take from a bank, you will get a year or 5 years time. But if you take from the company, you will get only 12 months. Okay, 12 months, because they will be taking OD in their name and giving to you. But the thing is that you can have an agreement with them. For marketing, for example, if you are taking some, suppose you are taking a laser machine for them. If you buy from them, they will contribute to your marketing too, because it's their liability, because they have it's the machine, everything, loan is in their name. So the thing is that if possible, get the company loan rather than bank loan. Negotiation is always open with the companies.
Thank you, sir. Thank you. Thanks a lot. Moving ahead, now I call upon Dr. Mohsin Kadri for his talk on marketing your new setup.
Good afternoon, respected chair and dear delegates. Myself, Dr. Mohsin. I'm a urologist from Guntur city of Andhra Pradesh. Today, my talk is on marketing your new setup, digital and physical marketing for running your own clinic. No conflicts of interest. So as a urologist, I can touch up superficially on what is marketing and what is digital and what is physical marketing and how it helps in running our clinic. At the same extent, I want to quote NMC guidelines regarding the marketing. So first of all, what is marketing? It is the action or business of promoting and selling products or services. It includes marketing, research, and advertising. Physical marketing is otherwise called as traditional marketing, which refers to the marketing which is not online. It means the print, broadcast, direct mail, phones, outdoor advertising like billboard, and from newspapers to radio. This is a lot. It reaches to a lot of target audiences. As I said in the previous slide, various means of physical marketing, that is traditional marketing, that is newspaper, magazine, flyers, brochures, radio, TVs, and on billboards. Digital marketing, the term digital marketing refers to use of digital channels to market products and services in order to reach consumers. This type of marketing involves the use of websites, mobile devices, social media, search engines, and other similar channels. So these are the type of digital marketing. I'll start from content marketing, where a concept has been selected and that will be promoted in the public and it will be marketed. At the same time, email marketing is where there is a lot of database of emails and the latest products, everything will be get notified to the subscribers. As well as influencer marketing is type of marketing where a person who markets is not a celebrity, and a person who chooses a product will likely in recent days we see a lot of Insta and Facebook. Many people are advertising the selected product and advertise that will become popular. That is type of influence marketing. And coming to viral marketing is concerned, This is a kind of a marketing where a group, a set of people suddenly focus on a thing. Like suppose, for example, electric vehicle is there. A group of 1,000 people suddenly tweeting about viral market, this electric vehicle. And suddenly the attention of a person who is not in search of that also will get the attention of that. Similarly, mobile marketing, where this is marketing entirely depends on whatever say apps or SMS, anything that relate to mobile and tabs. And electronic billboards and search engine optimization is one of the thing where in the Google search or any search engines, we can manipulate the content. And pay-per-click is concerned, it is a type of marketing where whenever a person clicks on the advertisement, the advertiser needs to pay to the publisher based on the clicks of ads. And finally, the social media marketing, what we are focusing on. So these are all 5 main social media streams which are essential in marketing, out of which Facebook, YouTube, and Insta are usual users are youngsters, teenagers, and youngsters. Whereas Twitter is concerned, educated people as well as wealthy people and few middle-aged people as well. Whereas LinkedIn, it's mainly by professionals and middle-aged group of people. Most of the marketing, what we see as for patient base is concerned, Facebook and Insta, and then is YouTube. So this is the strategy of social media marketing. First, we need to optimize the profile. So we need to create our profile first, and we need to add our websites, whatever other social media links to a main profile. And we need to post a useful information like any advertisements or like any awareness videos or any small short clips which is useful to public. We need to post it, and we need to measure, we need to engage how people are engaging, like how many likes we are getting, how many shares, how many comments, and whether we are getting followers are being added or not. We need to check it. And we need to advertise this by, they are called paid promotions, where we can pay money based on that money scale. The number of the it reaches the people of, and finally we can measure with the help of analytics in settings of each and website. We have analytics. We can see this post reached how many people liked it, how many of the new followers. We can do analysis. And the prerequisite of promotion is establishing a new setup is first a logo. A logo should be unique, and we need to have a name and the location well ahead of starting your clinic. These are the prerequisites to start promotion. For any promotion, personal, physical meet is very important. For example, if we're starting a clinic, and we need to really meet colleagues or first or doctors first, those who are who refer our patients first, like those who are senior MBBS practitioners or those who are like general physician surgeons who will refer to our cases as, and not only them, as well as our radiology colleagues and our pathologists or microbials, whoever, we need to meet them in person. We need to request them to attend our clinic. At the same time, we need to, we'll meet the heads of so-and-so departments like municipal office, DMHO, fire safety department, whatever statutory bodies we need for a clearance of a clinic, we need to meet them. And as well, finally, the local heads like some corporator or village head or mayor, MLA. By calling these people, there will be more footfall to the clinic, and that itself one of the promotion. And coming to promotion via print media, newspapers is a mainstay, newspapers, magazines, whether weekly or monthly magazines, and distribution of flyers, brochures in public places. And flexi boards, as we see, there were a lot of hospital ads and flexi boards like in our local areas at near signals, in very crowded areas, as well as we are surprised to see many such flexi boards even in nook and corner, like any villages or nearby. Were crowded nearby villages of the practice. And stickers, placing the stickers in public places like tea stalls and behind the autos. I have seen many ads of hospital ads behind the autos. And distributing the referral pads to people people were outreach, like medical shops or labs where people they reach for casual blood tests or some medicines. These people can help you give their stickers from the referral pad so that they can reach your clinic. Coming to electronic media, TV channels where they're either in the form of a scrolling ad or in the form of a 2 minutes or 3 minutes ads in the TV channels. And it is a mic canvas. This will be in towns. This is a very popular way of communication and promotion. And if we have a patient database, then based on their numbers, we can send bulk messages as well as phone calls that we start up a new clinic. And as we are aware that these days there were a lot of awareness talks in FM radios, as well as few ads as well. Coming to digital media, this is a mainstream. As I said in my previous slide, Facebook, Instagram helps a lot, as most of our patients like our page, they follow us, or they send friend requests, and whatever post we put, they will see, they will like, and they will forward. As well as in Facebook and Instagram, there are like stories which stay for a period of 24 hours, whatever the update you put, whatever the clinic location, whatever the thing, whatever the achievement, whatever the message you put, that will be in the stories for a period of 24 hours, and the people will see, and they will like it, as well as the posts which will stay on your wall forever. And in Instagram, there are a thing called Reels, where we can really share educational video of like a minute or 2 minutes. And Twitter tweets won't help much in building a practice, but really Twitter is a lot for our young urologists to learn tips and tricks. Like Dr. Said is here, Dr. Tanuj sir, and many other respected people outside the dais also. They share a lot of tips and tricks and troubleshooting that we help, that it helps our young urologists to build our clinical knowledge and clinical skills. YouTube uploading videos of whether awareness videos or short clips that helps in promotion. And LinkedIn posts, as the LinkedIn post is purely a professional marketing, that is that not helps much in patient building, but the HR people, employer people will be seeing whoever doctors are there, and that's a place where employers will catch. And WhatsApp, coming to WhatsApp, there is a business profile that is a very exclusively good profile. So in this business profile, we can add our name, degrees, and everything, our credentials there in the respected columns below, and we can mention our clinic timings, mention our fees there. A patient, when he goes to our profile, he gets in and out of the detail. Every detail we can paste it there, and he can understand everything from there, business profile. And whenever patient messages to the number also, there is a profile called a welcome message, such that whenever patient message, it will say thank you for contacting and so, and we can respond it later. That is a really very good big feature of business profile. And whatever statuses we keep, if we feed our patient phone numbers, and whatever status we keep, the patient also will actively seeing, and they will be commenting, liking. And Telegram is concerned, not much special, but there is a option of bulk messaging and forwards. And now here I am attaching the recent National Medical Commission Registered Medical Practitioners Professional Conduct Regulations. This is a recent one, and I'm reading these above points. Registered medical practice, the restrictions, there are some restrictions on advertisement. Kindly listen carefully. Registered medical practitioner is permitted to make a formal announcement in any media, whether print, electronic, or social, within 3 months regarding the following: on starting a practice, on changing a type of practice, on changing address, on temporary absence from the duty, on resumption of practice, on succeeding to another practice, and public declaration of charges. In this time only he is permitted to do a formal announcement. And printing of a self photograph or any such material of publicity in the letterhead or on a signboard of a consulting room or any such clinical establishment shall be regarded as act of self-advertisement and unethical conduct on the part of the physician. However, printing of sketches, diagrams, pictures, and human system all shall not be treated as unethical. A RMP or any other person, including corporate hospitals, running a maternity home, nursing home, private hospital, rehabilitation center, or any type of medical training institution, etc., may place announcements in the lay press, but these should not contain anything more than the name of the institution, type of the patients admitted, kind of training, other facilities offered at that place, and regarding the fees. A RMP is allowed to do public education through media without soliciting patients for himself or the institution he is working. And the conduct of registered medical practitioners on social media, these are the 3 key principles. The broader principle of medical ethics should guide the use of social media by RMPs. RMPs need to distinguish between telemedicine consultation and social media. All written and visual communication should be truthful, respectful, and professional. The conduct, RMPs can provide information and announcement on social media. However, the information should be factual and can be verified. The information should not be misleading or deceptive, nor should it exploit the patient's vulnerability or lack of knowledge. RMP should avoid discussing the treatment of the patients on the public social media or prescribing the medicines to the patient on the public social media. If a patient approaches doctors through public social media, the doctor should guide the patient towards a telemedicine consultation or in-person consultation as the situation warrants. RMP should not post patient's photograph or scan images on the social media. Once an image is posted, it will be owned by a social media company or by public. So RMP's behavior on social media towards his colleagues should be guided by general principles of medical ethics on professional behavior. RMP should not directly or indirectly indulge in practices of purchasing likes, purchasing followers, or paying money so that search algorithms lead to their name being listed at the top or registering on the software programs that charges fees for higher ratings or soliciting patients. RMP should not request or share patients' testimonials or recommendations or endorsements or reviews in the social media. RMP should refrain from sharing images of healed or cured patients or surgery procedure videos or images displaying the impressive results under any circumstances. RMP is allowed to share educative material for the information of the general public. However, communication should be limited to the expertise. RMP's webpage should also follow the same guidelines as above. On social media, RMP should refrain from boundary crossing or violations and conduct themselves with dignity and decorum. Soliciting of patients directly, indirectly through social media is unethical. My take-home message is marketing is need of hour in this current era of competition. Both the physical as well as digital marketing are essential and need to go hand in hand for the promotions. Whatever the marketing tricks may be, should not violate the National Medical Council, Registered Medical Practitioners, Professional Conduct Regulations. Thank you one and all for your patient listening. Thank you
Dr.
USI and Youth USI for giving me this opportunity, and Jai Hind.
Thank you, Dr. Mohsin. I already covered everything and we are running short of time. So we'll be inviting the next speaker for the talk now. So we need to know about the statutory clearances, which ones we have to get, when we start our practices, the MOUs, the rent agreements. So we have Dr. Parimal Gharia for this insight to all of us. Over to you, sir.
Thank you, Youth Organization of USI, for inviting me for this talk. We'll be talking about the statutory clearance. By the time we have reached this, we have decided to start our own hospital. And what the statutory clearances we need to find out by that. The first thing is to register the owners. Either we want to register as a proprietorship or a partnership firm, or a limited liability firm, or a private limited company. We need to decide first who are the owners of the hospital. Second thing is a process. Process is a development permission. It is to be taken by the land owner or a developer. It is to be taken from local municipal corporation. It grants, popular it is known as a Raja Chithi. It is a permission to start the construction of the premises. After the completion of the building, that comes with a completion certificate that certifies that the building has been completed, and then comes is an occupancy certificate. Some state calls it as a possession certificate, some state call it a BUC or a building use permissions. It can be obtained from the local municipal corporation, and it certifies that the building has complied with all essential building rules and regulations. It is only about the building and not about the hospital. Recently, this is in very news after the fire in few hospitals in Ahmedabad and during the COVID time, and it's a BUC, is a building use permission. A few of the group of doctors has approached the Supreme Court about the closure of the hospitals, and Supreme Court has clearly mandated that all hospital must have a BUC for the use as a hospital. It has been very highlighted by Dr. Aditya. Then comes is a fire NOC. It is to be taken from the in-charge fire officers. Previously, the getting a fire NOC was independent of the legality of the premises. But now by the intervention of courts, now it has been mandatory to get a BUC certificate to start a hospital. And for fire NOC, you need to have a BUC. So the legality of the hospital is checked, the premises is checked by the before giving you a fire NOC. Then comes a clinical establishment. It is a national act, and some state has already adopted that and some has not. But if you are starting a hospital in a state where the Clinical Establishment Act is adopted, then you have to fulfill the state-wise categories of the hospital, and you need to see that in what categories you are starting a hospital, and according to that you need to have that specific requirements for that hospitals. In Gujarat, that is no Clinical Establishment Act, but either it's a Form C, or in Surat it is called Gumasta, or in Surat we have adopted the Bombay Nursing Home Registration Act. So all hospitals or all clinics has to be registered under Bombay Nursing Home Registration Act. Then comes is the biomedical waste. You need to have two type of biomedical waste management clearances. First is a BMW Authorization Form 3 under the Rule 10. It is from the Pollution Control Board of the state. Then you need to have an MOU with the biomedical waste facility in your area or a facilities. So these MOU, when you are getting the MOU with the biomedical waste facility, make it sure that the BMW facility is government recognized, and these facilities should have Pollution Control Board of that state permission to have a biomedical waste management. Then the lift license, it requires regular renewals. All X-ray equipments requires AERB, Atomic Energy Regulatory Board approval for C-arms and use of an X-ray. Then comes an ultrasound. Ultrasound unit must be registered with PCP and DT Act. Chief District Health Officer gives you the permission to have an ultrasound machine. Not only the machine, all the doctors using that machine has to be registered. You cannot have a person coming from outside and doing USG at your place and not having the register with that machine. That is also in violation of PCP and DT Act. And if you are a urologist using exclusively using the sonography machine, you have to file an every month 0 report with PCP and DT department. There is no exclusion, no excuse for this. Then comes is the Rohini. Rohini is a registry of hospitals in network of insurance. If you want to start a reimbursement claims or a cashless claims, you need to register under the Rohini ID, and it is a 13 digits globally unique GS1 identifier. It has having geocoding for the location also. Then comes is the Form 17C. The many multinational companies or big companies are spending money on their staff or staff's expenses, medical expenses, and their relatives' expenses. This requires Form 17C to claim as a reimbursement for that company. So it is the requirement of a bigger companies to have the hospital should have a 17C, and you need to attach with this type of corporate patients, you need to attach a copy of this. Then comes is a professional fee. Hospital and all the employees of hospital has to be registered with the professional tax. Registration of birth and death. Now it has been almost online portal, and everyone has to hospital has to register for this. If you are starting in your own hospital pharmacy, then there has to be a registration of establishment. Then has to be a drug license. Then the pharmacist registration. Then the narcotics registration. Like in Surat, we have a registration for Spirit, Narcotics and Psychotropic Drugs Act. Most of the pharmacy requires a GST number. So you need to register under the GST only also. And sometimes at some hospitals, the income tax department had asked for a separate bank account for a pharmacy to need to define the pharmacy, because many hospitals were negating the profit of a pharmacy to a hospital loss. So this has been now a compliance of separate bank account. And if you are starting an kitchen, then FSSI license, ambulance license, arms license. If you are using your security is using the arms. Now if you are purchasing in a hospital, if you are not planning to purchase a hospital and start a hospital in a rented premises, what type of agreements you need to need, and what the nuisance of this premise MOUs is. So first you need to decide is that the premises is constructed on a free land, which is owned by a landlord, or here the premises is already a constructed building. A constructed building can be a large commercial complex, and that hospital is a part of that commercial complex,
or a proposed site is an individual standalone building, already a constructed building. Who will make the plan? Decide on first that who will make the plan. Either a developer is making a plan and you are just doing an interior work, or you are giving the plan to the developer and he will develop the plan according to you. Getting an approval for construction is a tedious and tricky job and may sometimes require some undertables. So it is better to be left with the developers. Decide the total duration of rent. Usual rent agreements start with the 9 years. So if you are planning for a long term, you need to negotiate according to that. If the lease is more than 25 years, you may ask for a land and the rent agreements according to land and construct the building according to you. The duration depends on the next plan move. If the plan is to purchase another place at some point of time, it is better to have a shorter duration of agreement. But if you are planning for a long term or a longer duration, you need to decide first, because once your business is established, you cannot move out and the landlord will ask a hefty hike then when the renewal comes at the 9 years. And by deciding the duration, you need to also count the center of business. The center of business of the city changes every 10 years. So once you are in a very prime area, within 10 years, that prime area is in the side of the city and you will have to move to another place. So this is a center of business concept is to be kept in mind. So what is the next 10 years, 20 years, the hospital will run or not. Then is a notice period. Notice period is a tenant has to notify to the landlord that I am leaving this place within these months. And it is depends upon the duration. If it is a longer duration, either it's a 3 months. Try to negotiate as hard as possible, because you never know that at what point of time you need to close the hospital. Can landlord ask the tenant to vacate the lease or rented place? In 3 conditions, if the property is not used for the specified use, the legal issue about hospital or illegal activities established, then the landlord can ask the tenant to vacate the property. Lock-in period. The lock-in period concept is important. It is not about the minimum, it is a notice period. It is a lock-in period. If you are renting the premises for 9 years, if your lock-in period is 3 years, and if you want to leave that place within 2 years, you cannot leave. You have to pay for 3 years minimum. So lock-in period concept has to be kept in mind. Area of rent. Specify in the MOU that in what area you are giving the rent. It is a super build-up area. It is a total constructed infra, including the staircase or entry floor, or it's a pure usable carpet area. Then decide about the rent increment, at a 1 yearly increment, 3 yearly increment, or the 5 yearly increment. Rent-free period. If you are starting in premises, you are making an MOU, then you have to decide about the rent-free period. That after these many months, I will start the hospital. For these many months, I will have a rent-free period. Try to negotiate as longer as possible. And if it is not possible, try to establish that after getting an BUC, after 3 months or 6 months, I will have a rent-free period. Because getting BUC is sometimes tedious job and it takes 6 months and your rent starts. Date of the rent. Fix the date at like on every 7th of this month, I will give the pay rent. Rent deposit. Sometimes the builder asks you for a rent deposit. Either it is routinely just 6 months. Always and always include force majeure in your rent agreement. Force agreement is act of God. It's a natural calamity. 2 slides.
But we'll have to, we can just go through the headings, right?
Yeah. Man-made disaster or state imposed ban. Registration of rent agreement is important. Right. Try to get first right of refusal if landlord want to sell the premises. Construction inclusion and exclusions. Water, gas and electricities. Water tank and lift. Maintenance of premises. Structural maintenance to be landlord and municipal taxes by a landlord. Decide first how the disputes will be settled. Either arbitration is always, who will be the arbitration if the dispute arises. And sometimes the builder may ask for a security deposits. You need to negotiate on this. Thank you.
Thanks, Dr. Parimal. It was a very, very big topic. You did a justice to it. And I'm sure that these slides, people will take snapshots and see it online. Thank you so much. Thanks to the chairpersons. And then I'm going to hand over the stage now to Abhishek.
So that brings us to the end of an exhaustive 1.5-day session. We'll have a small valedictory program for which I request Honorary Past President of Urological Society of India, Mallikarjun sir, to be on dais. I invite Chairman YOU, Dr. Zishan bin Hamid on the dais. Mallikarjun sir, briefly your comments on this 1.5 days program. Yes. Then we.
Yeah. Well, I think Abhishek, I've seen the program. I've not been here for some reason or other. It's a well-crafted program, what I saw. Probably as the time passes by, we should be getting into that specified topics and division into a much more focused areas rather than general discussions, which have happened in the last 2-3 decades. One thing is, well, I think the program has become much more wiser and better now. One is technical talent, second to conceptual talent, third thing is business talent. All three things have been very well mixed and programmed well. Congratulations for all of you to craft a great program and possibly, and I think you'll have some things coming up in near future like innovations and you've done your research, etc. Wonderful. And I think you'll improve it much more better in the next future too.
The highlight of 1.5-day program was the presence of Dr. Syed bin Hamiri, who flew all the way from Middle East. We all follow him on Twitter, take his tips, and indeed it is our proud privilege to honor Dr. Syed. Syed. So indeed, this sets the ball rolling for international YOU collaborations. On that note, the last bit of our valedictory function, the practice-changing publications, the 2 publications that have, in the eyes of the jury, change the publication, change the practice, or is likely to change the practice. The first award for this category in the 3rd Youth Conclave goes to Dr. Santosh N. The second award in this category goes to Dr. Vivek Venkatramani. So he is not with us this afternoon, and I'd request Dr. Nirja to collect the award on his behalf. Now, it is my indeed proud privilege to thank this August gathering. I start by thanking the USI Council for
I thank Secretary Dr. Keshavamurthy sir, President Professor Ravindra Sabnis sir, past President Mallikarjun sir, President-elect Sanjay Kulkarni sir, and the entire USI Council for backing us up tooth and nail. This program is completely supported by Reddy's Lab, and this wonderful premise of Leadership Academy has been provided to us by Reddy's Lab. So we can't thank them enough for their effort. Indeed, this program would not have been possible without the delegates being present here. I thank all the delegates for their continuous support on and offline. I thank seniors, Dr. S.K. Singh sir, Dr. Lalit Shah sir, and Dr. D. Ramesh sir for their presence and gracing at this occasion. I thank our previous council members and chairman, Dr. Dilip, Dr. Tanuj, Dr. Raman, for their tireless effort and guiding the new team through this program. I thank the ladies who made and given a separate flavor to this particular endeavor. In particular, I'd like to thank Dr. Kinju Adhikari, Dr. Swagarika, Dr. Neerja, and Dr. Saundarya for their efforts. I thank one and all for this wonderful effort. Thank you.
Please come. Please. The lights. Yeah, lights.
Let's go. सऊदी अरेबिया जा रहे हो बाबा अगला सईद बिन फैमिली के पास चल भाई हमें आपको